Bom dia. Vamos começar a sessão teórica do 5º curso de Doenças Pulmonares Difusas. Quero dizer que sinto muito gosto em que estejam todos aqui e que é o 5º curso, como está referido no programa, e muitas coisas mudaram desde que nós começámos a fazer há 5 anos este programa. Inicialmente o nosso objetivo era ser um curso formativo, nomeadamente orientado para os internos complementares, uma vez que não havia, na altura, nenhuma formação no seu percurso que os orientasse para as doenças mais difusas, e de maneira que achávamos que isso era uma lacuna muito significativa. Entretanto, de facto, nestes últimos 5 anos muitas coisas mudaram, uma das quais foi essa. De facto, neste momento existe essa alternativa, o que muito nos agrada, dado que as doenças pulmonares difusas são uma parte componente das doenças respiratórias e, como tal, devem ser tratadas da mesma forma que todas as outras. Por outro lado, houve várias coisas importantes que se passaram nestes últimos 5 anos. A principal foi, de facto, neste momento haver uma terapêutica diferente para uma das doenças que neste momento, de facto, é aquela que mais interesse desperta em todos aqueles que mais lidam com estas doenças, que é a fibrose pulmonar idiopática, e isso, obviamente, que leva a que haja uma dinâmica diferente relativamente ao interesse que as pessoas têm. E de facto, também por isso, levamos a que consigamos hoje ter uma reunião que pensamos ser mais completa e mais abrangente. O ano passado fizemos o degrau de termos um especialista internacional com intervenção na broncologia, mais propriamente com a realização de criobiópsias no próprio serviço, o que penso ter sido um passo muito importante. Neste curso, aquilo que quisemos, o passo seguinte foi tentar aproximar as outras especialidades das quais dependemos para uma abordagem diagnóstica e não só, mas em termos de monitorização destas doenças. De facto, os workshops que vamos organizar em termos de radiologia e de anatomia patológica, o objetivo deles são não só formativos em termos dos especialistas de pneumologia e dos internos de pneumologia, mas principalmente, ou também, tentar sensibilizar os colegas da radiologia e da anatomia patológica, porque sem isso não conseguimos fazer as coisas de forma correta. Para isso, gostava de destacar aqui o apoio que tivemos da Boringer e da Roche, que sem esse apoio não seria possível termos esta evolução no curso. Hoje é a sessão teórica e iremos, a parte da manhã, será um programa sobre uma das maiores dificuldades relativamente à abordagem destas doenças, na minha opinião. Iremos falar da pneumonite hipersensibilidade, mas principalmente das maiores dificuldades que a pneumonite hipersensibilidade encerra. E a saber, principalmente, tendo a ver com a pneumonite hipersensibilidade crónica, que, na minha opinião, é o principal problema que nós temos, e isso não é algo que seja transversal a todos os países europeus, nomeadamente, e nós temos esse problema particular e que nos põe muitas vezes problemas de diagnóstico diferencial com outras, nomeadamente com algumas pneumonias intersticiais. Por outro lado, outro dos problemas maiores que temos relativamente a esta patologia é sabermos qual é a sua causa. E não é um tema isento de controvérsia. E de maneira que penso que esta sessão é útil. Certamente que, espero eu, que seja uma sessão controversa. De facto, vão ser discutidas aqui coisas que não existe um pensamento único acerca desse, ou um consenso acerca desses assuntos, e de maneira que penso que teremos todos os ingredientes para ter um bom programa. E, para além disso, obviamente, que temos os palestrantes que me parecem que melhor poderão falar sobre esse assunto, e é de facto, mais uma vez, uma honra e um gosto imenso tê-los aqui nesta instituição. I would like to welcome our guests. We are very pleased and honored. We hope that you enjoy our session. Eu convidava o professor Paulo Cordeiro para fazermos a moderação e forma também de agradecimento destes 6 anos em que esteve à frente da Sociedade Portuguesa de Pulmonologia e que, de facto, pela sua sensibilidade para a patologia pulmonar difusa, ajudou a que muito tivesse evoluído durante este período. Vamos então começar a sessão.
Going to begin the session. Professor Otto Wells is a specialist from Brompton Hospital. Of course, we all know he is a main reference. And the title of his presentation is Hypersensitivity pneumonitis. Should it be viewed as a single entity?
Thank you very much, Antonio. Can you hear me at the back? Can you hear me at the back? Good, splendid. I would like to start with a famous stress test. In just a moment, I'm going to show you pictures of 2 identical dolphins. And this is a well-known stress test. You must study the picture closely and look to see if you can see differences between the 2 dolphins. And what I need to tell you in advance is that if you do see major differences, you are in urgent need of a holiday. Now, are you ready? Concentrate. And I thought this was an appropriate start because this is the question we are confronting in hypersensitivity pneumonitis. So we have 2 dolphins which are in fact under the same name but very different creatures. And my lecture today is very much when we examine the dolphins of hypersensitivity pneumonitis, can we actually see major differences? So this broadly is the plan. I have to cover some historical data. Then I'm going to take you through a multidisciplinary study which for the first time takes data from the same centre, the Brompton, and takes this to 7 expert groups in 7 countries. And 2 participants here today are Federino Paletti and Antonio. Then I'm going to discuss the disease behaviour classification and how this might apply to hypersensitivity pneumonitis. I'm going to take you over separations in outcome between subgroups of patients with what we might term chronic hypersensitivity pneumonitis, and then close with just 1 or 2 final thoughts. But it's good to start with the traditional classification, which I guess most of us grew up with in medical school. The idea that hypersensitivity pneumonitis could be neatly subdivided into an acute group, a subacute group, and a chronic group. And I can remember that when I grew up, it was believed that acute hypersensitivity pneumonitis was the most common form. This is what used to be said, and that referral centres were seeing selection bias, and then it became apparent with time that the acute form was relatively uncommon. This wasn't just selection bias to referral centres, but the separation into systemic symptoms with fever, sweats, malaise, sometimes no abnormalities on a chest X-ray, clear-cut relationships to exposures, and consolidation sometimes on imaging. But the sort of disease we encountered in hospital practice divided between subacute disease, often insidious in onset, generally or often without systemic symptoms, a diffuse abnormality. I think you're going to have a lot of CT scans later from David Hansel, so I'm not going to show examples at this stage, but widespread nodules, often difficult to see, mosaic attenuation on a scan, and generally a good outcome with antigen withdrawal and immunomodulation. And then a separate group with chronic fibrotic HP, and much of my talk is about that group of patients. But this is a statement in itself. In a Brompton Hospital study of consecutive patients with a first-choice multidisciplinary diagnosis of HP, 102 consecutive patients, the CT scans were scored as subacute, mixed, or chronic, and you can see that, at least as formally scored, there was a large subset of patients with features somewhere between the two. Now, David Hansel said to me yesterday, I'm not sure I can believe that, and all I could think to say was, well, you scored it. But I'm sure he'll have something more to say about this a little later. But the fact that it is not always possible to separate the scans in this sort of way, the observer agreement was moderately good for this grading system, not exactly brilliant, with a weighted kappa value of 0.46. Now, this was very much a landmark paper, and Dr. Morel, Costabel were both members of this group, and this was published now 12, 13 years ago. And this was an attempt to predict that subgroup of HP patients with what might have been called active disease. So the definition of this group required support from a BAL lymphocytosis or CT features, and the HP cohort, in some cases, patients did require a surgical biopsy to make the diagnosis. And 116 patients were mixed together with over nearly 300 ILD control subjects and other forms. And the idea was to try and identify those features in clinical practice that allowed you to make a diagnosis that had actually been made based on BAL and CT. And in this study, there were 6 factors that were identified. So, exposure to a known antigen, antibodies identified, recurrent episodes of symptoms, crackles on examination, a bit unfashionable, I suppose, symptoms occurring 4 to 8 hours after exposure, and weight loss. And this was very, and it was confirmed in a subsequent cohort. And the authors conclude the diagnosis of HP, often made with confidence or excluded, especially when there's a high prevalence of disease, without the need for BAL or biopsy. Now, it is important to highlight one issue. In the introduction, the authors state that they were examining patients presenting with a suspected diagnosis of acute, subacute, or, importantly, chronic HP. But then they go on to say that patients with, and I'm quoting the exact words, inactive late emphysematous or fibrotic sequelae of HP did not count. So if these features were identified, the patients were viewed as not HP. They were actually put in the control group. So this is an important point. This wasn't a study of everything we might call HP. I'm citing word for word from the manuscript. This was a study of that group of patients who have a lavage that you do not call active HP with fibrotic disease, but they progress and they die. I guess we always knew that, but over the last 10 years, with more focus on what is IPF and what is HP, we now understand that there's this large group of HP patients who have a different sort of activity, not activity you can reverse with a good outcome, but activity that leads to respiratory failure and death. So I think it's only fair to point out that the same authors, I think it's worth mentioning this first. I'm going to come back to this later, but this is the first subdivision made by these authors within HP, and the table here is the disease behavior classification, which was endorsed in the revision of the idiopathic interstitial pneumonia classification 3 years ago. And this describes the patterns of disease behavior that you might see across interstitial lung disease. So you have here 5 patterns: reversible and self-limited disease, reversible disease with a risk of progression, and then various forms of irreversible fibrotic disease, so stable with residual disease, progressive irreversible disease where with therapy it's realistic to stabilize, and then progressive irreversible disease which continues to progress in spite of treatment. Those are the 5 possible patterns of disease behavior you can encounter. And to sum up what I've told you, the study of active HP, I suggest, was largely focused on these 2 categories: disease with a better outcome, with a lavage lymphocytosis, without fibrotic sequelae on CT. So this was that subgroup of HP patients in the first 2 categories. I'm going to come back to this disease behavior classification, but let's just focus again on what we might conclude from what was a keynote study. And one issue was a misunderstanding that arose from the study, I suggest, because the title of the study was The Clinical Diagnosis of HP. And this caused a number of readers to promote the idea that you can't diagnose HP without a BAL lymphocytosis, when in fact I think the study was saying you can't diagnose the entity which is more active without a BAL lymphocytosis. By definition, if you didn't meet criteria and you had fibrotic sequelae, you weren't in the HP population. That is the wording of the manuscript. Ulrich is shaking his head, and I'm sure that he will correct this later. I have that feeling, and I'm only relieved he's not standing to his feet to correct it now. So, can we say that in any case, these authors then studied this question again in 2009, and they made this key separation, and this study deserves to be cited perhaps more widely than it is. So this is now actually reappraising the entity of HP and defining two clusters. And that, I think, is much, much closer to, yes. 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 Yep. Right. Yeah. Yes, what seems to have happened here is that you started with, here we are, I think I'll find it. Yes, you had 116 patients that were called HP in the first population. And now you've added in those that you moved out of the HP, and you actually end up with 168. So you've taken 52 patients that weren't called HP the first time, that are now studied as HP. Okay. Yes. Yes, and what? Yeah.
Derivation and validation cohort combined, and you see that most of them, 2/3 of them, had chronic fibrosis. What was said by fibrotic sequelae would correspond to your patients with stable residual disease. Yes. We included those who were not progressive, were considered to be rather inactive, and sequelae means just small fibrotic scarrings, but no fibrosis, diffuse NSIPUIP-like pattern. That was not excluded. Just to make this comment here, to clarify it.
Suspect
so it was.
Much
I'm sorry that we didn't do the right wording, but this is a complete, let's say, misinterpretation of our study population.
I suspected as much, but the problem is people read the study and read the exclusion as a problem.
And so about the BAL lymphocytosis, the cut was 30%, and those who had below that were still included as HP when there were other features suggestive. Around 30 of these didn't have a BAL lymphocytosis. It was just considered a so-called minor gold standard, and it was not that they had most of them active, acute or subacute disease. That's not correct.
Which makes a lot more sense with what I'm going to discuss later. No, I always suspected, reading the study, that there must have been some extra wording to be added to the patients that were excluded, and you've confirmed that. But I think the key point is, if there was any misunderstanding, the next study made the separation very nicely, that there were these two clusters, which comes out of the 2009 paper. And one of the values of this, I think, is that there was a comparison between the two clusters. So recurrent systemic symptoms, the chest X-ray often normal, and you're talking here, doing the maths quickly, of about 25% of the total, 41 out of 168. And then a second cluster with traditional interstitial lung disease, including evidence of fibrosis on CT. And when you compared these two clusters with capturing, I believe, the sort of distinctions that have been useful over the years, there wasn't any good correlation between the breakdown into acute, subacute, and chronic. And one observation that was made is that nodules on CT were equally prevalent in cluster 1 and in cluster 2. Now that, I think, is a fair interpretation of that study, Ulrich, yes. So I think that kind of removed anyway any confusion that arose from the first study. And I must make a confession, I was a reviewer of the first study, so if there's any confusion, I didn't comment. It's my fault, so I'd like to make that clear. One shouldn't really admit these things, but I guess it's 13 years later, so it doesn't do any harm to say, actually, speaker attacking himself. But I think that what came out of this is we've got, if I go back a slide, we've actually got an entity described in cluster 2 that is a very non-specific ILD fibrotic entity. What's special about that which is HP when you read wall clubbing, hypoxia, restrictive lung function, fibrosis on a scan? There's nothing in those 4 features that tells you HP rather than IPF, rather than fibrotic NSIP. So how exactly are we going to diagnose this? And this takes me to Simon Walsh's multidisciplinary study, which is, I think, about to appear online in Lancet Respiratory Medicine. So what are people like at agreeing on a diagnosis of HP? Now, this is the first study, I believe, to take data from the same institution. These data come from consecutive patients discussed in the Brompton multidisciplinary meeting and taken to expert groups in 7 countries. And don't please ask me to identify each flag, but I know as a fact that the Portuguese flag and the Italian flag are both contained here because the study was done with Dr. Mirage and Dr. Paletti as key participants. And you have 70 cases, 22 with histology, evaluated by expert groups, and the study design was similar to studies performed in the past. So the first step was that clinicians, radiologists and pathologists, each of them within each multidisciplinary group, individually evaluated data and reached a first choice diagnosis, but up to 5 diagnoses with percentage likelihoods, adding up to 100%. And then there was a multidisciplinary step where each individual group reached again a first choice diagnosis and up to 5 diagnoses. They also predicted disease behavior. They identified a management strategy, and the clinicians before this step were asked to say whether they would choose to biopsy that patient or not. And these are the results between multidisciplinary groups. And I should just highlight with reference to HP, this statement here made in the NSIP workshop some years ago, the particular importance of a multidisciplinary discussion in distinguishing HP from NSIP. Now, just a question to you. How many in the audience understand kappa? I don't mean you read kappa and you say kappa means the test agrees. How many of you understand how kappa is derived? Shall we have a show of hands? Those people who understand how you get to a kappa value. Okay, 3 people. How many of you actually don't feel you don't completely understand kappa? Show of hands? Quite a few. Look, it may be that what I'm about to tell you is the most important piece of information you'll walk away from the talk, but I'm going to give you a 3-minute summary of kappa. Are you ready for this? Okay. If you get 2 people looking at grades, So suppose they look at a scan and they're distinguishing between IPF and HP. And you're examining whether they agree. There will be a certain amount of agreement by chance. There must be. And you can very simply calculate the agreement by chance that you would expect. And it depends upon the distribution of the grades. So if 90% of your calls are IPF, this is taking the two scorers, 10% are HP, you will have agreement by chance of 82%. So if you call randomly with that distribution, you'll agree 82% of the time. Now I'll give you the most easy to calculate scenario, and that is half of your calls are HP, half are IPF, and in that case, if they're randomly assigned by chance, you will agree on 50%. A kappa value of 0 means that you have chance agreement. It doesn't mean you have no agreement, it means you have the chance agreement that is correct for that breakdown of grades. A kappa value of 1 means you have perfect agreement. So the kappa tells you how far you have travelled from chance agreement to perfect agreement. It is that simple. So if you have chance agreement of 50% and your actual agreement is 75%, you have gone halfway from chance agreement to perfect agreement. So you have a kappa value of 0.50. And so that is all a kappa value is telling you. And an acceptable kappa value is 0.40, and that's all right for a test. If your agreement is less than that, the test is unlikely to be helpful. Now that's a bit surprising when you think about it, that you only have to get 40% of the way from chance agreement to perfect agreement, and that's all right for a test. If you think about it, though, the fact you're not doing better than that is because often it's difficult to tell disorders apart on a test, and you can actually tell the clinician that if you're a radiologist. You can actually say, I'm having trouble on this scan because it is close to the division between HP and IPF, and the clinician is still getting useful information if you're saying that, even if you're saying there's going to be disagreement between observers. That's why a good kappa value is 0.60, 60% of the way from chance agreement to perfect agreement. So you can now look at kappas and assess agreement in the study that I've mentioned for the entities under discussion, and so I will give you the kappas. 7 expert groups, that's NSIP, kappa value of 0.25. So from this study, these expert groups had a level of agreement on what is NSIP that is below the level that is useful for a diagnostic test. Then let's go to HP with a kappa value of 0.24. I'm not going to present the IPF data. The kappa values were up in the 0.6s for IPF, and maybe that reflects the fact that people around the world have talked about IPF. They've talked widely, they've talked repeatedly, so they can agree between expert groups on diagnosing IPF. People haven't talked about HP, they haven't got together. They've got different classifications. Some people are still using acute, subacute and mixed. Other people are using the clusters that I mentioned. Other people are using their own systems. But the upshot is that 7 expert groups actually are not agreeing on what is HP. Now, I'll give you one more interesting capper. As a clinician, would you perform a biopsy? Want to have a guess of that capper? No, a bit better than that. 0.23. Surgical biopsy. I think we'd do surgical plus cryobiopsy with the repeat study in 6 months' time. But these are some of the basic levels of agreement between expert groups. So I think you'll agree there's a problem in actually diagnosing HP coming out of this study. Expert groups can't agree. So let's break this down a little. What is the value, anyway, of making a diagnosis? Why do we bother? Well, we bother potentially, obviously for many reasons, but if you were actually underlining two of the most important reasons, it might be clinical utility and pathogenetic insights. So in other words, making a diagnosis can inform you on the natural history, the likely natural history and treated course for clinical purposes, or it gives you insights, you understand the disease better, you develop new therapies, but all of that is not very useful to the clinician in routine practice. So does HP stand up to scrutiny? When you make a diagnosis of HP, does this give you reasonably accurate information on what is likely to happen? And I'm going to come back to the disease behavior classification. So I think just to summarize, the disease behavior classification was endorsed in the IIP update for patients with unclassifiable disease. The advantage of the classification is that you've got a huge number of ILD entities, but you can subdivide patients with chronic ILD into just 5 groups based on disease behavior, treatment goals, and monitoring strategies. And these again are the 5 groups. Now, already I've made the point that in active HP, these patients are included, and based on Ulrich's description today, plainly, sorry, I've skipped ahead, plainly, some of the patients in the Lacasse study would fall into these categories here, but certainly these categories are represented. Now, this is an HP patient, man in his 50s, presented with long-standing disease, clear exposure. He declined therapy, and in the years ahead, his disease remained stable. This man had residual disease, which was now non-progressive. The next patient presented with a shorter history, again, a likely antigen exposure, a BAL lymphocytosis, and this CT sequence, but he had immunomodulation, and from that time, over 5 years, he's declined only minimally, subliminal subclinical progression. So broadly, this patient has progressive irreversible disease, but was stabilized. The next patient had HP confirmed at biopsy, received extensive immunomodulation, but progressed like IPF in spite of all therapy and died. And the point I want to make here is if you actually take the spectrum of HP, you have patients in all 5 groups of disease behavior. So if you're viewing HP as a diagnostic entity and you're saying that making a diagnosis of HP tells you about the likely natural history and treated course, it does not pass that test because HP patients can lie in any of the 5 groups of disease behavior within ILD. Now, I can't make the same sort of statement about pathogenesis with great confidence. So, making a diagnosis of HP, does that tell you about a unifying pathogenesis? Are the treatments we might use across the whole spectrum of HP? But I must have to say, I think, that I doubt it based on just this and 1 or 2 other studies, that if you examine the underlying histological patterns of HP, you see this sort of spectrum. Typical appearances of HP, this is a Moises-Selman study in quite a large cohort of bird fancier's lung, and 110 patients undergoing a biopsy, and patients with NSIP, UIP, mixed disease, organizing pneumonia, airway-centered interstitial fibrosis, and an unclassifiable group, with the UIP patients having a worse outcome than the others, and the NSIP patients having a better outcome. Now, that may not tell you about pathogenesis, but this is as great a spectrum of patterns as you might wish to see under the same entity title with differences in outcome. So by the time you put these things together, it may be incredibly valuable to make a diagnosis of HP because you'll remove an antigen. Distinguishing between HP and something else may be very important. But the virtue of making a diagnosis because it gives you some confidence about the likely disease course or captures unifying pathogenesis, I suggest is very difficult to argue that in the case of HP. And I don't think we should worry about imprecisions of wording under the valuable older studies, by the way. I think they're all making the same point, that there's confusion about the words because there's confusion about the entity. And I think this comes through with the confusion of different disease behaviors, different histological patterns linked to different survival outcomes. So I'm now in the rest of this talk going to focus on the group which is more broadly chronic. And this was a multidisciplinary study that we've just completed, and Venerino is the second centre. The Forley Centre is the second centre involved in this study. But it asks the question, given that ideally a diagnosis should tell you something about the likely natural history and treated course, can we use the things that we use to make the diagnosis give us subgroups with differences in outcome? And in particular, can we find the subgroup of patients within HP that have an outcome that is similar to IPF? And so we had a total of 102 consecutive patients with a multidisciplinary diagnosis of HP as first choice, a confirmatory cohort of 61 patients from Forley, and a control group of 84 patients with IPF confirmed at biopsy. Now, I apologize for this slide, but this is just in case people think the multidisciplinary first choice diagnosis was, in some cases, a desperation diagnosis. These are not diagnostic criteria. This is confidence of diagnosis. And here we're amalgamating antigenic history, in many cases supported by precipitants, in some cases a convincing history without precipitin support, the CT features, the lavage findings, and in 48 out of 102 cases, a biopsy. And I think you can probably focus on the probables. There are various combinations, but this wasn't a matter of guessing a diagnosis in unclassifiable disease. And based on diagnostic confidence, we excluded 30 patients where the diagnosis wasn't made with any level of confidence, and we were left with definite highly probable, and probable. And I just want to highlight one or two things about the cohort. So 83% had lymphocytosis over 14%. Antigens, in fact, if you regard a possible antigen exposure as no more than possible, in this cohort, disease was antigen indeterminate in 54% of cases. In a parallel Chilean cohort, it's 55%, and I believe in the Denver cohort, it's approximately 50%. So in hospital practice, as opposed to referral center practice, antigen negative disease quite frequent. You've seen the breakdown of the CT patterns, and these are the factors predicting survival. This is in the 102 cases at the Brompton, and in common with other interstitial lung disease studies, age and disease severity. But the other features were the lavage findings and the CT pattern, acute versus subacute versus chronic. Let me dispose of the CT pattern. That did not identify a group of patients with an IPF-like outcome. So the worst group in CT, the chronic HP cases, still had a 5-year survival over 60%. So the money from this lay in the lavage data. And lavage thresholds were evaluated, and the best thresholds were a lymphocytosis of less than 20% with a hazards ratio of nearly 4, and a neutrophil percent of 6%, a hazards ratio of 2.6, and they remained the best thresholds with adjustment for a whole number of things, including treatment status at the time of BAL. And a quarter of the cohort had a lymphocyte percentage of less than 20%, a neutrophil percentage of greater than 6%, and the hazards ratio went up to 5.4, and in the 4D cohort, that picture, the confirmatory cohort, smaller numbers, 61 patients, but a hazards ratio of 7.7. So immediately you had a lavage profile that went with a worse outcome. And when you then combined these, those patients with a lymphocyte count of less than 20% and a neutrophil count of above 6% had only a slightly lower mortality statistically than in the IPF controls. And when you adjust for disease severity, there was only marginal significance. Disease severity was important. You can see here that in this group, about a quarter of the cohort with HP, you have this separation into a group with a mortality that's a lot closer to IPF than to the remaining patients who had at 5 years a survival of 90 to 95%. So you've got this subgroup who have an outcome close to IPF. Now, I'm going to close now with just, I think, 3 or 4 slides, just to pull this together. How am I doing for time? Ulrich? Okay, good. So what does this mean? We've got a group dominated by what we might call chronic HP, with or without an element of subacute disease, which one suspects is going to be a minority of what you see on a scan. And why is it that this breaks so distinctly into 2 different outcomes? And could it be actually that we have a group of patients who have epithelial injury with an HP pathway, but that IPF follows from a number of epithelial injuries, we know this epidemiologically. It's not just smoking, it's a number of airborne exposures that have been linked in epidemiologic studies to getting IPF. So why should not damage to the epithelium as part of HP, why should it not be a trigger for getting IPF? Maybe there's a good reason based on T-cell subsets or something, but certainly you have this group of patients called HP based on reasonable diagnostic grounds that have an IPF outcome, and we know that a number of them will have UIP on histology. Now here's another one. How much of HP is secondary HP? We know that in IPF the epithelium is damaged. We have epithelial integrity in health, and it's monitored tightly in normal health. It's a normal range which is reasonably tight. And on Darwinian grounds, that's going to be because it's necessary. So could it be that by having epithelial injury, we are breaking down the barrier between the environment and the immune system? And we actually have a number of patients who in reality always had early IPF, but because of what had happened to the epithelium, they then reacted in a different way to inhaled antigens and developed the features of HP. This is sheer speculation. I'm merely focusing on the fact that there is this subgroup of HP patients who behave like IPF. Now, I'm not sure about the others of you. I've never dared to try and report this because it's so difficult to nail prevalence, but I'm quite convinced over the years that there's this group of connective tissue disease patients who have HP as part of their spectrum of connective tissue disease ILD. They present with HP, and this happens more frequently than one would have expected. And that maybe relates to epithelial events in CTD, I don't know. So that's another possibility. Those are two speculations. Can we close them with future treatment implications? So we need therapies for those patients who behave like IPF with a diagnosis of HP. That's to say our treatments are failing. And we know that in IPF you've got multiple co-activated pathways, you've got two highly pleiotropic agents, and we know that on the data we have across fibrotic diseases you have major overlaps of pathways. And in HP, after all, UIP is a subset. So from this, it would seem to make sense that we should be trialling pirfenidone and nintedanib in progressive HP, or we should be exploring novel forms of immunomodulation such as rituximab. And indeed a trial is underway of the progressive fibrosis phenotype. It's in advanced planning and it should start recruiting later this year. Non-IPF patients with progressive fibrosis, nintedanib. And the dilemma is, do you go on using immunomodulation with an antifibrotic agent, or do you make a switch? So in summary, I'd like to close again with this slide. To make the point, we have this entity called HP, but actually there are major differences between the dolphins. And so here's a more traditional summary slide. Our previous classifications do not meet patient needs. And viewing HP as a single diagnostic entity, I'm merely repeating, I think, what people have known for a very long time, but trying to flesh it out a little with what has happened in the last decade. In non-active HP, you have a subset with IPF-like disease behavior. So they may not have a lavage lymphocytosis, but they certainly progress in a way which is close to IPF. And so in the future, subclassification based on BAL thresholds, based on the principles of disease behavior, may give us a way ahead. Thank you.
Thank you very much. It was a stimulating lecture, as always, and it is open to discussion.
Well, I think there's a lot of topics for discussion. Of course, you elegantly show us and tell us the kappa value issue. Can I know exactly what is the kappa value of the Brompton multidisciplinary team?
0.11.
In which concern distinguish HP from fibrotic NSIP? That is, that might be a problem in the clinical distinction. So what is the kappa value in your multidisciplinary team?
I think it's the problem of a gold standard, a reference standard of any kind. And one of the difficulties is that you can try to distinguish between HP, the group that don't behave like IPF, and IPF. But if you've got a group of HP patients who do behave like IPF, you don't have outcome to be able to go back and say we were right or we were wrong in saying they had IPF or HP, because actually this subgroup have a very similar outcome to IPF. And the same applies to the more benign group who have a similar outcome to NSIP. So if you've made the separation based on BAL, and we do actually discuss this routinely in our meeting, how can we tell based on outcome that the more benign group is really HP and not fibrotic NSAP? And how can we tell based on outcome that the more malignant group is progressive HP and not IPF? So we haven't got an answer. And in our multidisciplinary study, we didn't have a reference standard. We weren't able to say that one or another group was wrong. All we were able to say in the multi-country, multidisciplinary study is that people could not agree. It's not the same thing.
It's not the same thing.
I'm not sure Ulrich needs a microphone, actually.
Arthur, thank you. Brilliant ideas. And just one comment on the kappa values. You said the kappa value in your multi-country MDD for IPF was quite good, 0.6.
0.6 odd, yeah.
0.6 something, and for the other two entities, NSIP and HP, it was really poor. Probably we have agreed on diagnostic criteria for IPF now, and we don't have agreed on diagnostic criteria for HP and for NSIP in the same way. And because you didn't standardize that beforehand, you left it open to the individual centers, probably that is a major issue. And that would be something for the future, that we really do the same as we did for IPF, that we agree more on the diagnostic criteria. It's just a comment, right? And I know you want a second question, then you can answer both, is did you look separately in your prospective cohort by, let's say, do some sensitivity analysis, omitting those 30% where you did not have an antigen exposure? What would be the outcome? Would you still have such a nice separation of an IPF-like disease behavior? That is one question, because we have in our institution around 1 to 5% only with unknown antigen exposure. We are really very careful not making the diagnosis without antigen exposure, even if the CT would show something like that, or even when the biopsy shows granuloma. How specific are granuloma for HP? Yeah?
So two separate questions, and there's a bit to say on both. I suggest there might be two things that are making agreement on IPF much greater. And you're absolutely right. Of course, the first of these two things is agreeing on criteria. But the second thing is that it really matters to clinicians, and they're doing this a lot. And I'll tell you why I think that. One of the things that was evaluated between centres was IPF-like disease behaviour. And the kappa value for that, so it's category 5 of the disease behaviour classification, in other words. The kappa value for that where it's not defined so rigorously was 0.60. So because it matters to clinicians because of antifibrotic agents, they're talking about IPF a lot, they're looking at disease behavior, they tend to agree. So it's a combo of having formal criteria and it matters a lot. But what I do take out of this is that there's an urgent need to get together to define what we mean by HP and to agree on approaches to classify it. And by the time you've taken the acute, subacute, chronic, the key observations on the two clusters, and I see the two studies of your group as telling a tale and moving the emphasis from one emphasis to another, perhaps. Is that fair? So you've got the two clusters in the end, and then difficulties in taking the ILD cluster. Yes, there's an urgent need to get together to agree on this. Now we come to the second point, and I have to tell you that's the bit of our study that I'm left with some unease about, because I think there is major variation between attitudes in centres about antigen indeterminate disease. So how far are you going to go by saying that you won't diagnose HP with a really rigorous search for an antigen? The problem again is the great variation in the way people feel about searching for an antigen. And I know this because of the IPF consensus statement that is just running to its conclusion, where you have a group of 20 expert clinicians around the world, and they're voting on tests, and among the tests they're voting on are HP precipitants, and a third of the group just don't think the tests should be routine in suspected IPF which isn't diagnosed. A third of the group think maybe it's a good thing and we should support units that actually do this so they can report, and a third of the group do this routinely. So in other words, there's no agreement. There's just no agreement. I know that you feel strongly that you should search for antigens. I believe you do as well.
I talk about this in a minute.
Yes, right. But there's no agreement on this, and people need to get together. Now, in our centre, antigen indeterminate versus antigen determinate made no difference in outcome. But I think that's the second reason as well. We're getting the most difficult disease referred to us. So we're getting the antigen determinant cases that are doing badly. And they do match the antigen determinant cases and the indeterminate cases. In some other centres, there's a broader spectrum. You actually have the antigen determinant cases doing well represented, and then you can see differences in outcome. So it depends on the nature of your population. And then it depends on your attitude to searching for an antigen at your centre. And again, we need to get together to agree on that.
Okay, I think we are facing the universal problem of the lack of accuracy biomarkers in pulmonary diseases.
Yes.
It is the case. But now it's time, first Tom Vivanerino and then you, okay?
Thank you, Arthur, for your presentation. The correlation between IPF and HP is fascinating, and my question or my comment regard the fact that in familial IPF you can find histological pattern identical to HP or even granulomas. I remember cases with documented mutation of TERK with hypersensitivity pneumonitis pattern signed out by our pathologist. And we, in our familial series, we have a trend of increased lymphocytosis in patients with IPF compared to patients with sporadic IPF. So I think your hypothesis is very, very interesting. Can you comment on it?
With some difficulty, because the question you then come up with is, if you don't see an antigen, have you actually got a different disease in that case? Whereas I guess in the HP population I'm describing, you can actually reach an HP diagnosis. But let's imagine that we're constructing a model where if you have active HP with a good outcome, what you have is an appropriate response to a higher antigen load, and maybe with the antigen indeterminate disease, you have a markedly aberrant over-response to a tiny antigen challenge. And so are these the same diseases? And in your familial IPF population, do you have a group of patients who are having inappropriate over-exuberant responses to tiny antigen load? So I don't know, is another way of answering your question. How many of your familial IPF patients actually have some abreaction to environmental challenges? And is this actually triggering their IPF, or does the IPF in some way create the abnormal response? What do you think? Good. Yeah. Yeah. Yeah.
Thank you, Athol. The obvious issue with HP is, as you said, that we don't have a gold standard.
Yeah.
I have my gold standard under the microscope. David has his gold standard by CT scan. There's lymphocytosis. So I have a view of HP that's microscopic, histologic. And I was interested by your comment about collagen vascular diseases starting as HP. To me, under the microscope, they're different diseases, and I just wonder if you could elaborate on that. Are you talking about a triggering mechanism or an actual histologic response?
Not an occult histologic response. So I'm talking about a group of patients with CTD who have as their ILD manifestation a typical CT picture of hypersensitivity pneumonitis, looking nothing like the other CTD-ILD subset. I'm talking here about a rare finding that occurs from time to time, but I would think, trying to avoid the fact you always remember the same case and go back to it, I believe about 10 cases in the last 10 years have had an HP present and have an underlying connective tissue disease. That's the best way to put it. I'm not here referring to the bronchiolitis of CTD, because this is a true HP entity in terms of the interstitial element. But for all intents and purposes, HP generally along subacute lines in a setting of connective tissue disease. And the idea being that we know there's a lot of epithelial damage in connective tissue disease, so maybe that is in some way making the individual more susceptible to inhaled antigens.
Well, I just remember the lady with rheumatoid arthritis that I saw a biopsy on, and because she was unable to get around, she bought a bird.
The last question, we have to move on. Yeah. I will make a question that I think is in the mind of many people here in the room. Consider that parameters with bad prognosis. Do you feel that patients have to be treated differently? Second question, don't you think that maybe the clinical trials ongoing that should be focused on that patients?
Yes, to both questions. So let's define it a little more. If you have features on a CT saying there is significant irreversible fibrotic change, and you have that lavage profile, I would at this stage, if I could, use a combination of some immunomodulation, because I don't believe the lavage separation is perfect and there's a group that will benefit. But I would like to use an anti-fibrotic agent early in that group. And possibly if they present with moderately severe disease, not wait to see them progress in spite of treatment. I mean, I'm talking about what I would like to do if I was allowed to. I mean, we can't use these drugs in the way that we would like to, based on common sense and logic. So we have to have trials. And the only issue for the trial that is about to happen was, how do you power studies looking at a series of entities that are not common enough to study in the sort of numbers you need. And that is why the study design is a mixture of progressive disorders that are not IPF. It's about powering. Now, it would be really nice to do a study in this sort of population I've presented with chronic HP, but what we've had to do is develop a study design of the progressive fibrotic phenotype, where you're amalgamating progressive CTD, ILD, HP, idiopathic NSIP, unclassifiable disease, and in fact, even sarcoid is included, rightly or wrongly. So you're actually taking the progressive fibrosis phenotype as a group. So yes, to both questions.
Thank you very much.
Well, I think we have to move. Thanks, Atul. First of all, I would like to congratulate Antonio for the organization of this 5th course on diffuse lung diseases. The last time I was here in this room, around 4 months ago, it was for the brilliant discussion of Antonio Moraes' PhD thesis. So I'm very happy to be here again. And I think that Antonio Moraes, the most recent professor of pneumology in Portugal, deserves also an applause also for promoting this program.
Isto foi uma partida.
Secondly, I would like to thank you for inviting me to co-chair this outstanding panel on the focus now is mainly on IPF, but I think this is a very important disease, also in Portugal. Just as an example, I have to tell you that in our national program of lung transplant, we have a higher number of patients with chronic HP in the waiting list than IPF. So it is a very important problem in Portugal, the chronic HP. And also it is, for me, good that it is a disease where BAL is still a very important tool. So now it's time to listen to Ulrich Costabel. Everyone knows Ulrich Costabel from Essen Rural Clinic. He still is working there, although he is now emeritus professor. And we will be very happy to listen to the etiology issue in HP. Please, Ulrich.
Thank you, Carlos, and thank you, Antonio, for inviting me again to this great meeting. I enjoyed already last year very much these discussions we had, and it seems to evolve in the same way this year, together with Athel and with Venerino. Great discussions we had during your presentation. And now I have the difficult task to search for the etiology. You have heard that 30 to 50% of HP diagnosis is made without the etiology. Is this really reasonable to do that? Well, we have heard that it's not really clearly defined. We heard something about pathogenesis, so the objectives is now in this talk to tell you something about the antigens, the search for exposure because it's relevant for diagnosis and obviously also for prognosis. Well, first homage to Portugal. You know this? Probably everybody has done it already. The cork bark cutting to get the good corks for the Porto we enjoyed yesterday evening. It was really delicious.
And also for red wine.
So there is a strong relationship to Portugal with this famous type of HP which is called suberosis actually. But I will not carry oils to Athens. I will not say anything about suberosis in the following because you know much more about this disease than I do. Well, we have heard about from Athens that it's really a complex syndrome. I would not say it is different entities, but it's not a unique, single, well-defined disease entity. That is true. And it's also not amazing because it's a response to such a variation of avian proteins, dust, microorganisms, chemicals. I will not talk about any chemicals anymore in the following. And unknown exposures, variable clinical presentations, variable natural histories. We heard about the progressive forms, the self-limiting forms. So it's a complex syndrome. Just a brief insight into the pathogenesis. We need surely an inducing factor. Yeah. And then we have exposed individuals, and many of those will not get disease. They have the exposure but not develop antibodies. Then we have subclinical alveolitis group. This is a patient who has some antibodies, who may have a lymphocytosis in BL but no disease. And then we have the full-blown disease, which first is inflammation, and then some of those go to fibrosis. We don't understand the factors so far why some go into fibrosis and some not. And to get the disease, probably there are host factors, important genetic background, smoking history, less prevalent in smokers because smoking protects obviously the macrophages from immune responses. They are dampened down and so they cannot respond properly. That's a sort of cure of immunoactive disease. Well, and also viral infections have been proposed as triggering factors for HP. In the immunopathogenesis, we know that there are two types of immune reactions. Type 3 reaction, which is caused by the IgG antibodies, the precipitins that are formed, and then we have sensitized cells, the T cells, which are finally involved in granuloma formation. And we can use also the T cells to look in the lab for sensitization against antigens, and especially we can see the T cells, the cells in the BL, also as evidence of exposure actually and sensitization. Well, the type of antigens, there are long lists in the literature, and it starts always with farmer's lung. That was the first disease that was described back, I think, 300 years ago in Italy, and then it was further developed in England. Why in England and Scotland? Because the weather is awful. Humidity, so much humidity, winters, moldy hay, so the poor farmers, they suffered a lot from farmer's lung. Before they got silage, actually. Now it's better. Humidifiers, air conditioning. I was just recently in Bangkok, in Singapore, in both hotels. I had the moldy smell, the moldy odor. This is humidity, this is air conditioning, also something we have always to consider as a source of antigen. Steam iron. Yeah, we have seen very few cases with steam irons and being exposed to bacteria developing in steam irons. Woodworkers, moldy wood, important sources. Then a lot of occupational exposures, maple bark, stripper's lung, the thatched roof lung, bacchososis, which uses sugar cane. In Jamaica, frequent disease, for instance, mushroom worker's lung, barley, contaminated barley in malt worker's lung, and so on, a long list. And again, in Switzerland, this cheese washer's lung, when they have the moldy cheese with pernicium, and the dry sausage worker's lung in Barcelona, I think you have described it, Ferran, the dry sausage worker's lung, and so on. A very long list. And now more importantly than the animal proteins, and it's usually avian antigens. All these fur animals like cat and dogs, they don't make it. I don't know why, it's just the animal and the birds. The feather-duvet lungs must be considered. I will talk a little bit more about that. And so on. Really a long list, and we cannot keep all this in mind when we do the history of the patients. Well, what are now the major types which are really important? I want to show you this paper from the Mayo Clinic, causes and features in 85 consecutive patients. Most of them had a chronic disease. 78% had a chronic form. And it corresponds very nicely to our own data. 85% of our HP patients have the chronic form, only 15% the acute. And the cause identified in just 75%. In 25%, the antigen was not identified, and the majority is avian antigens. I think there's now very consistent findings all over the world. Avian antigens #1, and then the molds. And interestingly, in this North American series, hot top water was 21% hot top lung. That is for Europe quite unusual, I think. We don't have this high series. And we have around 75% avian antigens in ours and 25% molds in Essen in Germany, actually. Well, what to do when the antigen is not identified? 22.5% in this series. What to do when we have a CT like this, where we really think it must be HP, or when we have this mosaic attenuation in the background of diffuse ground glass, also very suggestive. What to do in a patient who has these characteristic suggestive CTs, if he's not a smoker, or if he has a BL lymphocytosis of 80%, some plasma cells, really very suggestive. It can be organized pneumonia, but you have no consolidation. And this is just to remind you what you see in BL. High lymphocytosis is characteristic, mild increase in neutrophils, plasma cells, you can see foamy macrophages, and the ratio can be normal but also elevated, especially in the chronic forms. Well, what to do? Maybe there are some entities you are not aware of, like metalworking fluid-associated HP. This is usually mycobacteria, bacteria in the fluid associated, a fluid which you use when you polish metal in such occupations, hot tub lung, swimming pool alveolitis, or we recently had a misting fountain alveolitis epidemic in Germany by these nice fountains, and these were contaminated with bacteria. But this was different, this was acute settings, and if you have an acute form, it looks like pneumonia. The patient may go to a hospital for pneumonia for 2 or 3 times, and then if he recovers very fast, the 4th time, usually the doctors consider this might be some type of HP, and then you can do a re-exposure. It's not so difficult to recognize it than in the chronic forms, where you don't have this acute presentation. So the rarer environments and causative agents are listed here, like the feather davits. It's a very important cause, and usually you ask, do you have birds? But that's not the complete and single question you should ask. I come back to this later. Or the dry sausage lung, and saxophone players, wind instrument players, they can have the fungi in their instruments, and they grow there and they get the disease when they play the instruments. Or somebody who took care of the foot, Chiropodist lung was recently described in the German literature. Well, various new diseases can happen, and that's just a summary of a review of certain patients with feather david lung. All were females. Duration of exposure because maybe the males don't work with the feather david so much. Yeah, so I don't know, but it was really interesting. New feather davids, and it can last prior. The symptoms ranged from 3 weeks to greater than 5 years. 5 patients had kept birds in the past. 4 of them without symptoms, so sometimes they past bird exposure, maybe sensitization, and then they get the disease with new feather davids. And 3 had intense contact with goose in the use. And 6 had chronic, 7 acute HP, so both is possible with this. Careful, ask for this in the history. A new etiology was last year published, argon. I have never heard about it before, but it's used worldwide in cosmetic products. Argan oil from this tree you see on the right, I think this was from Morocco, from North Africa. It's nuts contained in the fruit of this tree, and there were just 2 patients amongst 9 argan workers who developed HP. A new cause can be behind it, and you don't know the etiology. So another thing is there is a wide variation, geographic variations. In Europe, mostly we keep the small birds, budgerigers or the canaries. In Mexico, they have the pigeons at home, so it's a different type of exposure. Moise Selman, most of his patients have the pigeons at home. And a very specific disease to Japan is summer type HP caused by trichophyton, which is a fungus growing in the tatami mats in their houses in summer when it's very humid in the rainy season. So this is also something you have to consider in the history. And these are the parakeet or budgerigers, actually, the most frequent cause in Germany probably. And the type of exposure determines also the clinical form of disease. So the acute is really usually occurring after high-level exposure, like the pigeon breeder when the pigeon's stable is cleaned, or the farmer immediately after feeding moldy hay to the animals. He gets symptoms after 4 to 12 hours, flu-like symptoms, respiratory symptoms, and this is also reproduced in inhalation challenge, usually this acute with high-level exposure. But the chronic HP has continuous, very low level exposure. You will see later how low the exposure level can be actually. And sometimes it's really so low and not evident that we don't recognize. And this goes on like IPF, like any fibrotic lung disease. So for the diagnosis now, these are really not very precise diagnostic criteria, but you usually need findings of ILD, right? The radiograph physiology should be like an ILD. You need the exposure. You need evidence of sensitization by finding the precipitating antibody. Then you can do a bronchoscopy and BAL to demonstrate lymphocytosis. And surgical lung biopsy is rarely needed. And you know why? You can find HP, okay? If you find UIP, NSIP does not exclude HP. This is for me the biggest problem actually. We know that UIP and NSIP-like histology can occur in HP patients. And you can do an inhalation challenge. I will show you results of Farron Morrell's extensive experience, how this can also be used, but only in certain centers, and mostly we don't do it. For instance, we did it in the past for certain occupational exposures just to demonstrate for sure before recompensation, reimbursement for a worker that it was a true HP. You have seen this paper before, and we discussed already about that it was really the vast majority had also chronic HP. The vast majority had avian antigen, 75%, and 25% had mold exposure. Just to make the comment here, to search for the antigen. You know, here, these were the 6, and this is why it was called clinical diagnosis. It was not based on histology, not based on CT, not on BL lymphocytosis. Just if you have very simple clinical information from history, from auscultation, and you can make the diagnosis. If you have all these 6 features, in 98% it is HP, right? Just exposure, precipitants, recurrent symptoms, the crackles you hear, symptoms after exposure, systemic weight loss, and it's through this. You don't need BAL, that was why it was called clinical diagnosis. It doesn't mean that we don't suggest to use any more HRCT and BAL for making the diagnosis. And you know, the odds ratio just for precipitants was 5.3. It was the second after exposure. So indicating that precipitants are really useful as a diagnostic test. That's my opinion about the precipitants. And if you don't have, let's say, the exposure, look here on this left column, no exposure, serum precipitants positive, it's still 62% probability of having HP. But this decreases enormously if the exposure is not known. Well, how go we now on to detect exposure? There are some questionnaires which may be useful where you list all these type of exposures and ask the patient to fill it in. You can do investigations of the environment, look for the mold plates, let's see, and go into the home of the patient. And you can also look at the serum precipitants. Well, exposure history, ask the right questions actually. That is really the most important things. Look at the birds in the home or at work or in the neighborhood. It's not enough to ask, do you have a bird? The patient will say, no, I don't have a bird. Ask, when did you see the last time a bird? And then he remembers, oh yeah, my mother-in-law, she keeps a bird. How frequently are you there? Oh, maybe every second month. Or the mother says, I don't have a bird, but my daughter keeps it, and she's a student, and she brings her clothes for washing every week and takes care of, and this is already enough to get exposure. So indirect exposure is extremely important. The feather pillows, feather davits, mattress covers, also look at dead birds. You see feather decoration, feather wreaths. And one patient actually, his bird died, and then he had a nice feather wreath on his dinner, on his living room table, every day exposed to the feathers of his dead bird. Another one, he had a collection of stuffed birds in his home. You know the stuffed birds, dead birds, which are then nicely prepared And this was exposure. So he will say, no, I have no bird at home. And his companion, his wife said, oh no, we have with all these stuffed birds. Another thing is really you should ask the consort or the companion and take the history together. In many cases, the patient doesn't give you the answer, but some of his family will then tell you what is happening at home. Or consort HP, avian antigens transmitted by partners. Interesting situation, a 62-year-old pensioner gets divorced. He has a nice young partner, right? And then he sees the partner in her new home or in a hotel room, and everybody gets sick. Very inconvenient situation. Yeah, you have a new friend and horrible. Every time you get a disease, flu-like disease, and what can it be? You have no idea about it. And in this nice paper, they found out the previous ex-husband he was a pigeon breeder, or he had kept birds, and now these birds, some of the furniture was moved from by the wife to the new home, so there was still furniture, though it was extremely cleaned, everything. And you see here now the antigen detection. The blanket on the sofa in the couple's house, high content. Carpet in bedroom of ex-married, though they cleaned it actually. Then the guest room in female's bungalow, that's a new bungalow, still contains them. The bureau floor, a high number, 478, and also the bedroom floor in the female's bungalow. So a lot of exposure transmitted by these very minor antigens, and this poor guy always got sick. No. Well, another report was that somebody moved into a new house, and the owner in the house before had kept birds, and it was clean, it was really clean, but still this patient got bird fanciers lung. And I myself had a patient who really took away their curtains for cleaning purposes 6 months after the bird had removed, and she had cleaned everything, and she had a mild attack of subacute illness again. Another one, it was a pigeon breeder's wife. So she moved, she really could tell her husband, get rid of the pigeons. He did it, but they were in a pigeons breeders club, and they went for a club party, and all the pigeon breeders came there, of course, nicely dressed and probably showered and so on, and she danced with the pigeon breeders, and she was sick for 2 days, yeah? Probably they didn't wash all their hairs, the pigeon breeders, so there was some transmission of exposure just by dancing with pigeon breeders. So you see, it's very, very difficult, obviously, and very, very low exposure is sufficient to get the disease. Well, moles look for visible contamination on the walls, floors, furniture, or on clothes. One of our patients who got finally transplanted for HP, he, after 2 years of disease, and we didn't know why he progressed, his wife said, oh yeah, we just recently went into the cellar and we had some clothes there, some jackets, and they were really moldy. And it was not noticed, and he knew that he had HP, that he should remove everything. Sometimes they just don't find it. Just humidity, vapors, hot tubs, indoors, steam irons, and so on. Known water damage, fluids from floods, leaks, broken pipes, and the cellars. In Germany, the cellars are a problem. They are often high humidity, and maybe some liquid goes into it. So this is really something you must look for and ask the right question. The specific IgG now, the precipitins, they are really indicative of sensitization, of course, not proof of the disease. And the panel you use, it should be different in the different countries, in the different situations. The antigens are different. So we use routinely avian antigens, Bacteriger, pigeon, canary, and just 2 microbial antigens, Aspergillus and Micropolysporophene. This is our precipitin panel, and we find it actually quite useful. The significance now, these are older data, but just to show you that HP patients have maybe 60 to 100% positive precipitins, but also health exposed. Individuals have precipitins, so if somebody has a precipitins, it doesn't mean that there is disease, whereas not exposed usually have very low levels or not measurable levels. But the intensity, the antibody concentration can also give some clues, because this is an older data from Scotland, and you see that of these 277 Scottish pigeon fanciers, around 27 had disease, and those who had greater 90 antibody concentration, 7 of 7 had a disease. Those between 30 and 60, 3 of 9 had disease, and if you went down below 4, only 8 of 193. So it depends actually also the antibody concentration, the titer magnitude can also give a clue. The same was found for farmer's lung in Dutch farmers. Also look at the right side, IgG antibodies above 0.5 in the ELISA were associated with farmer's lung, below usually in asymptomatic farmers, and very low around 0.0 only in healthy controls. I want now come to the problem where precipitants might become negative and the evidence of sensitization is lacking. So this was actually the first paper that showed the different histopathological entities in chronic bird fancier's lung. By Yoshizawa's group, Professor Yoshizawa from Tokyo, he had a lot of papers, very interesting papers, also now recently produced some other interesting papers I can show you. And in this context, they had patients with a chronic bird fancier's lung. What were the criteria? They had to have a history of contact antibodies and or lymphocyte proliferation, test to avian antigens positive. Interestingly, this is done in Japan. We don't do it, probably you don't do it. And then some other criteria. Okay, there were recurrent patients, insidious patients, and the clinical diagnosis was usually IPF or idiopathic NSIP before they made then the correct diagnosis. So 40% had previously received a wrong diagnosis, and you will see data from your group, Ferran, in your talk, which look very, very similar. So that's dangerous, that if you don't find out in a background of IPF history findings that the patient may be exposed. Now, here you see 3 groups. Group A has a BOOP-like or cellular NSIP-like, so an inflammatory histopathology. Group B, fibrotic NSIP-like lesion, and Group C, UIP-like lesion. And you see immediately Group C, UIP, is around 10 years older, compatible age of IPF, the others are younger. Now, the finger clubbing also present in 82% of UIP, 0 in the others. There were some clinical differences. Now look at the sensitization. Anti-PDE or BDE antibodies, so that means precipitants positive in the UIP-like lesions, only 18%, not more than that. But the sensitization in the lymphocyte proliferation test was still positive in 91%. So that was probably one of the diagnostic criteria. They had really this sensitization just in the lymphocyte proliferation test. And another feature was also the BL lymphocytosis here in the bottom. Only 19% on average lymphocytosis. So a very low lymphocytosis in the UIP-like lesions, whereas the cellular-like or even the fibrotic NSIP-like lesions still had a lot of lymphocytosis in BL. And strikingly and not surprisingly, traction bronchitis, honeycombing goes up in the UIP-like lesion. And you see also the outcome was horrible in the UIP-like lesions. 5 of the patients survived and 6 died actually, and these are the survival curves. Well, this was just to show you, if you have a chronic fibrotic UIP-like disease, evidence of sensitization is often not possible anymore by precipitants or by BL lymphocytosis. So how can we now combine exposure history and precipitants in making the diagnosis? If you have both negative, exposure is negative, precipitants are negative, I think HP is widely excluded, even if you may have some hints from radiography or from mainly radiographic findings. if exposure is negative but you have precipitants positive, that is really the challenging situation. Then you should go back to the history. Then you should maybe go into the patient's home environment, send environment hygienist specialists, do some microculture plates into the home of the patient, whether some fungi grow there, and look where the exposure is. Precipitants, so I think they are really useful. You should not omit precipitants in your diagnostic battery if you suspect HP. If now the precipitants are positive, exposure is positive, precipitants negative, it's still HP because they may be negative, and if both positive, it's of course highly confirmative. Now, we can detect antigens by aerobiological or microbiological investigations of the environment. And a recent paper again from Yoshizawa's group, a very interesting paper, looked at the avian antigen detection in air samples and in the house dust samples. So they wondered how far can the antigen be transported through the air to the home of the patient, more or less. And the causative antigen was outside the home in 14 of the 16 patients. For instance, in one, 200 racing pigeons were kept 70 meters away from home, and still the patient had HP. Or a bird shop was next door. Birds in the neighbor's veranda, wild birds around the house, pigeons in all these situations. We had a patient with HP getting transplanted, and she got a relapse of HP, classical micronodules in the new transplanted lungs on CT. She got a BL lymphocytosis, and we looked, where was she exposed? Of course, she was very careful now with birds. And finally, we got out in the summer. She slept with open windows, and her bedroom was next door to a neighbor's house, and the neighbors kept a bird in their living room, and they had also open windows. And so that was a contact, indirect, transported through air, the antigens from this bird to the transplanted patient's lung, and she developed again HP in her transplanted lung. A bad situation. Such a bird was kept in the neighbors. And confirming this study, you see here now the samples were collected in front, airborne samples were collected in front of each patient's house for 6 to 24 hours, immediately in front of the house. And you see how high the concentration was outside the home in the air in these 5 patients with HP and asymptomatic breeders and not in controls. And of course, the same findings then in the house dust samples. Well, antigen avoidance test is something else you can do. You can take the patients to the hospital for 2 weeks to avoid further antigen exposure. And if the patient improves, this might be evidence of a HP. This is probably not possible if the disease is very chronic, but in these patients, they had chronic HP actually. They had chronic HP. And the diagnostic criteria for a positive test were 2 or more of either FVC increased by 30% without changing any therapy, so they didn't get immunosuppressive treatment, just went to the hospital. KL6 decrease, you know, this is a biomarker in Japan widely used for fibrotic lung disease, by greater 13%, or white blood cell decrease by 3%. Sensitivity was 51%, specificity 81%. So around half of these patients then responded in this antigen avoidance test. And of course, you can also do that in certain situations if you are familiar with doing this, with specific inhalation challenge. Different criteria are applied. I just want to show you this paper 2 years ago in the ERJ from Ferran Morel's group from Barcelona at Vall d'Hebron Hospital, suspected HP and specific inhalation challenge over 15 years in 113 patients with HP. In 81, it was nebulized antigen solution. Avian antigens molds were available, but in 32, it was exposure in a challenge chamber, natural exposure under working conditions where you didn't have the opportunity to make a solution. And the test was positive in 68, just 4 false positive, but negative in 45. In 24, even with HP, which was considered then to be false negative tests. And very interestingly, I like this approach in 11 patients where the causal antigen was not found. These challenges were performed to several suspected antigens without positive results. So if there is obviously no antigen found and you just pick up a list of antigens, it's very hard to detect really the proper antigen for your challenge, so it is practically useless. But the overall result was good, sensitivity 73%, and the specificity of this test was 84%. Well, why is it now so important to search for exposure? I mean, after hearing Asel's presentation, a little bit a nihilistic approach, yeah, you may, okay, have a disease behavior classification, you see how the disease behaves, and then you treat the disease behavior, but it's really, I think, crucial, and we agree on that, and Asel agrees as well. If you will be able to eliminate the exposure, probably the survival is better in chronic HP, even if you did not see this difference in your two groups with or without antigen exposure, because this paper from the National Jewish showed in a huge group of 142 surgical lung biopsy proven HP cases, antigen identified was only in 47%. What a shame. In 53% it was not detected. And again, the usual spectrum, avian antigens 41%, 27% mold exposure, and so on. And what was the outcome? And you see how the survival differed. It was really by 50% better. Median survival time 18 years when you knew the exposure, only 9 years when you could not identify the antigen. And this series, the median survival time of 9 years, of course, still even much better than IPF. Even these chronic HP patients had a better survival than IPF patients. Now another analysis was done whether you had fibrosis or no fibrosis on CT, I think. This was CT fibrosis. And you see that even in those who had no fibrosis on CT, those with identified antigen still had a better survival than those who had no identified antigen. And these were the odds ratios, the independent, or the hazard ratios, independent predictors of lower survival. You see, smoking was an issue, some lung function and fibrosis, but unidentifiable in antigen hazard ratio 1.76 for lower survival. Another study, again from Yoshizawa's group in Tokyo, published last year, chronic HP, 23 patients, and they measured the avian antigen in the dust samples from the household, and then compared those who deteriorated within by greater 10% in 6 months. So really progressive disease, greater than 10% in 6-minute decline before antigen measurement, versus a stable group who were stable before antigen measurements. And you see that the amount of antigens in those who progressed was significantly higher than those who had a stable disease. And this is, again, the same. Survival was better in those with a lower amount of house dust avian antigen before they made the diagnosis. So for diagnosis of HP now, I think really history of exposure, exposure-related symptoms, and also laboratory tests, positive serum precipitins, BL findings are important and should be done routinely when we evaluate these patients, just to have the potential to improve also the prognosis of the patients if they can get rid of their antigen completely, which is really crucial. So then, in conclusion, I think we agree now that this is a complex syndrome with various environment exposure conditions, a diversity of antigens. It's really important to search for the exposure. You must ask the right questions, and recognition or removal of antigen critical, may be difficult to achieve. Exposure history and precipitins contribute to the diagnosis. And you know, kissing birds may be a little event, and I thank you for your attention.
Thank you, Ulrich, for this excellent overview on the etiology and diagnosis of HP and the importance of focusing with a rigorous and very previous clinical story in which concern exposures. I don't resist to tell a short story that I heard from Thomas King last year in a meeting in Brazil. He showed a patient that completely compatible with an HP with no exposures. He asked her several times, no birds, no bolts, nothing. And but the clinical picture it was really an HP. And once the woman went to his visit with the little child, and again he was asking, so you don't have birds in the neighboring birds? And the little child said, "Ma'am, and what about Ralph?" He said, "Shut up, Ralph is family." It was a parakeet that they have at home. Ralph is family.
You see? Very good example.
It's incredible.
You always need a second person for the history.
Yes,
Because the person who owns the bird maybe they don't want to get rid of the bird.
Yes. Tiago, first question.
Yeah.
115.
Yeah.
Do you think this quantitative evaluation will change our way of seeing precipitants?
Yes, I
whether
think.
positive or negative?
Yeah, I think now it's. I still wrote precipitants, but usually now it's done everywhere by ELISA, by some ELISA technique to quantitate it, and then you have some cutoffs for normals, and you can also, as I showed you, see how high the concentration is. I think that it's an advantage, and it gives you more reliance maybe in the diagnostic value of this test, right? Yeah. If it's very high, I think that exposure is very likely. If it's just borderline, maybe questionable. Yeah. You must evaluate that as well.
Tom, Antonio.
I thought that was fascinating that there are these patients who have bird antigen out in the front of their house.
Yeah.
If you just took bird samples from the air of any city, wouldn't you find avian antigen there?
I am sure about that. Yeah, yeah.
So that makes me a little bit nihilistic about avoiding exposure.
It is really, you are right. That is a problem, and I mean, you should tell these patients, don't go to Venice, to the St. Mark's Square. Don't do that, because it is really a significant exposure. Yeah.
We have done this study, and we have catch an antigen in Barcelona in the ambience, yes.
Yeah, and they are high, right? You
Yes.
find them, yeah,
Yes,
yeah.
yes, yes.
I read a paper about Berlin. I think per year maybe 2,000 tons of pigeon dust is going over the city, and they really say these are the rats of the city, the flying rats of the city. That was the headline of this article: pigeons, the flying rats in Berlin. Yeah. It's amazing. And in Basel they had the very nice measures how to reduce it. They just strictly prohibited to feeding of the pigeons. So it was really like almost a death penalty if you feed pigeons in Basel. And then they really reduced their reproduction. Now there are a couple left, but tolerable. Yeah.
A comment and a question. I'd like, fascinating talk. I'd like to add one more question to searching for an antigen, and that is the person's car. So on 3 occasions, it's turned out that the antigen has been inside a car. Mold growing out of the window.
Very good.
In one case, and these really intense car exposures.
Right, yeah. Good.
So
I will add it to the slide. It's mold usually, right?
Right,
Mold,
right,
yeah.
right.
In the air conditioning of the car, and
That's right.
Or in a mats, yeah. In the car, automobile car, yeah.
So the questions.
German car.
German car, of course.
I shall go back and find
They are
out
heavily out of the pollution
Volkswagen.
concentration. Yeah. But also Mercedes, yeah.
So just to ask you about,
But not Porsche, no.
about this, do you believe the nature of the antigen actually influences the morphologic nature of the lung disease? So I'm asking you about that subgroup of HP that have emphysema-like change. And it has been argued, and it may be rubbish, I don't know, that different type of antigens actually affect the way in which the morphology manifests itself. So do you have a comment on that? And do you see these patients with emphysema in HP yourself?
Right. So I cannot answer actually about the histology where this would be different, because we rarely have surgical lung biopsy. Maybe, Tom, have you any clues about that when you see the HP, that you can tell something about the antigen which is involved?
Not in terms of emphysema, but in hot tub lung, where you respond to aerosolized mycobacteria, the antigens are the granulomas are much bigger, and they're different than what I call classic HP.
Okay.
So I think there is a different morphologic response, at least to those antigens.
And emphysema, we see emphysema in some farmers' lung. I think that was the first description, but we also see it in chronic pigeon breeders' disease. We have seen a couple of chronic pigeon breeders in our institution with a lot of emphysema and pulmonary hypertension, also excessive pulmonary hypertension, by the combination of emphysema and fibrosis. Similar like IPF combined, so that's maybe justification for the syndrome against CPFE, right, or not? No. Let's not discuss this today, no.
Ulrich, I mean, pedantically, I'd probably call it emphysema-like change, because it really isn't the same as the centrilobular paraseptal emphysema of cigarette smokers' emphysema. So it is a sort of emphysematous destruction.
Right.
It's very uncommon,
Right.
actually, but it's yeah, I think there's something odd about it. It's not like a cigarette smoker.
No, it's a different distribution, yeah. So it would be something else, yeah, than CPFE, yeah.
I think we are running out of time. Just a little question, Ulrich. Are you aware of any risk for HP related with nanoparticles? Nanoparticles are mostly based on carbon and metal, but we can have biological nanoparticles.
Maybe it might be a cofactor, a triggering factor, like viruses also, but I no personal information specific on that, no.
Well, I think we will do a break now for 15 minutes. It is, António.
Por favor, às 11h30, nós vamos ter coffee break. Como eu não referi isso inicialmente, como não há pagamento pela inscrição, obviamente que não podemos oferecer almoço, mas coffee breaks, quer da manhã, quer da tarde, tenho todo o gosto em o fazer. O almoço fica apenas para os inscritos no curso. Okay?
Yeah, no, you. Well, I cut away some. Yeah. No, yeah. I cut away some. Yes. Perfect. I cut away some slides.
Which one is?
It is this one, the second one. No, this one.
Check.
Yeah. I think it's okay.
I think I just remove.
sound check one.
With all the slides. Good. Yeah. Okay.
Shall I?
Hey, 2. Hey, teste. 2. 2. Tá bom. Hey.
Pronto? Buongiorno. 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 Dica.
I will check
was a really tough thing. No, just one, and the pneumothorax today is exactly the same. So we are going to extuflate, not drainage, extuflate, because if it's the same, the fistula stopped. But the fibrotic lung is not. Yeah.
So you will speak on Italian or Danish style?
Danish.
Danish.
Godt morgen.
Godt? I was. I was with Elizabeth Wednesday.
Yes.
In
Where?
Amsterdam. In the airport. The advisory, the Beringer advisory board for the. We are in the same group, media conference. Yeah, very similar to Danish.
Sim, sim. O problema, sabe, é que eu não quero pressionar muito, porque isto é a altura em que estão ali com as coisas. Do you have something in the
Some sort of images for reasons I have no idea.
Acho que temos que começar. Depois as coisas vão começar a complicar-se.
Vão entrando, por favor, e sentando. Estamos já um bocado atrasados. Não, é impossível começar agora.
Posso deixá-la aberta?
Não deixe fora as apresentações. Sim.
Ok. Fiquei, está aqui.
Só para ver, porque eu não consigo botar isto.
Dás mais um papel desses para eu tomar notas, já tomei notas, não? Obrigado.
Está a ser gravado já diretamente para o YouTube.
Mas não deve, porque eu pedi autorização para ficar aqui. Não,
Vamos ficar aqui no entregue. Mesmo na gravação, com qualidade. Eu estou a gravar o que está a passar aqui com qualidade.
Estás bom.
Vamos começar.
Muito barulho. Are you ready, Venerino? Ready? Yes, you must stop discussion, otherwise it will be very difficult. Well, we must move. Now we will have something for the second half of this meeting, different because we are going to have a very known Italian colleague and speaker, but he will do this conference in a Danish style, because, as you know, Venerino Poletti is now not only the head of the department in Forli, but also in Oros, and so I will welcome Venerino to speak on the endoscopic proceedings, the relevance of endoscopic proceedings in HP diagnosis. Please.
Good morning. Thank you very much to Antonio for this kind invitation. Yesterday, the blue-collar workers had a very tough day, but at the end, we had the opportunity to join with the philosophers in a very nice dinner. So thank you again for your hospitality. Hypersensitivity pneumonitis has different morphological manifestations, as reported in this very nice review by Jeffrey Myers. And in the subacute form, you can have the well-known triad with cerebral bronchiolitis, peribronchial inflammation, some organizing pneumonia, and granulomas. But in the chronic forms, you can have a different histological manifestation varying from airway central fibrosis, NSIP, sometimes organizing pneumonia, and even UIP pattern, or constrictive bronchiolitis. So the invasive procedures are useful to identify or to sustain the clinical or radiological diagnosis through the demonstration of specific or characteristic cytological or histological aspects. BAL, in fact, is a valid surrogate in the majority of cases of subacute HP because the cytological profile is very characteristic. You have a huge increase of lymphocytes. The lymphocytes are different from the lymphocytes you can have in sarcoidosis because they are activated. We call this kind of lymphocyte Lutzner-like because the different aspect of the nucleus. You have the presence of foamy macrophages, scattered mast cells, and mast cells are a very, very important clue for the diagnosis of HP, and scattered plasma cells. And another important point is that the total cell count is significantly increased in HP. HP and BUP can have similar cytological profile, but The main difference, at least in my experience, is the total number of cells. In HP, the total number of cells is very, very huge. But this is true for subacute HPE. When we are dealing with chronic HPE, this characteristic profile is not so evident. You have a decrease of lymphocytes and an increase of neutrophils. And in a significant subgroup of patients, lymphocyte can be normal, as reported in different papers, and in this paper by the Salmon group. CD4-CD8 ratio usually is lower than 1, but in about 3–5% of cases you can have a significant increase of this ratio mimicking sarcoidosis, and this is true mainly in, for example, in Japan. And this ratio vary according to the age of the disease, and this ratio is higher in the chronic phase of the disease. And of course, BL can be helpful also in cases mimicking IPF. This was shown by the Constable group not quite recently, showing that when you have typical clinical radiological spec mimicking IPF, if you have a lymphocytosis more than 30%, you have to consider HP1 as one of the first clinical hypotheses. So BL has a valid important clinical role in the diagnosis of HP, mainly in subacute HP, but also in the chronic forms when you detect a lymphocytosis. When you have this radiological aspect, the subacute HP enter in the differential diagnosis list and is in the first row probably. And if you need biopsy, and if you want to confirm the diagnosis using biopsy, transbronchial lung approach can be useful. With this approach, you can perform, of course, the investigation in the outpatient setting. You obtain usually tissue from the centrilobular zones, as shown also if you assess the slides obtained by regular forceps, because almost always you are able to recognize bronchioli and the accompanying pulmonary artery. But unfortunately, as shown by this very nice paper published in Medicine some years ago from the Barcelona group, unfortunately the typical triad, granulomas, centrilobular inflammation, and lymphocytic histiocytic inflammation can be recognized only in about 10% of the cases. You can increase this diagnostic yield if you increase the number of samples obtained. But if you consider only one of these three histological elements, the method can provide with information in about 70% of the cases. So I think this approach is an handicraft approach. It depends on, of course, on the operator, but transbronchial lung biopsy can provide some information in the majority of cases when the subacute pattern is considered. The problem is that when you have not this very characteristic clinical radiological aspects, but when you have a chronic a case in which you suspect a chronic HP, in which you can have different histological aspects varying from organized pneumonia, NSIP, airway central fibrosis, UIP with ancillary findings, small granulomas, some centrilobular damage, and so on. And in this context, probably regular transbronchial lung biopsy is useless, but we have a new approach, and it is transbronchial cryobiopsy. This technique was introduced in the field in 2009, thanks to the Jürgen brothers. They published this paper in Respiration, showing that with this approach you can obtain larger samples, and probably you can recognize difficult morphological lesions. Some technical notes: you use not a forceps but a probe with a metallic tip. You freeze the metallic tip using some gases. Nowadays, the only gas allowed to be used is CO2, and you can freeze the tip up to 50, 60 minus Celsius degree in a few seconds, and you can obtain tear away lung tissue in this way. You can use different probes. The largest one is 2.4, and usually we use this probe mainly in the lower lobes or in not small persons. And otherwise, you can use the 1.9 millimeter probe. And this is our approach. We perform cryobiopsy in a semi-surgical context using general anesthesia with propofol, remifentanil, spontaneous breathings. In some group, they use jet ventilation. We intubate the patient with rigid tracheoscope, and usually the stores 14 millimeters. Fogarty balloon or bronchial blocker is mandatory in order to prevent or control bleeding. Of course, the biopsy is made under fluoroscopic control. We use the Herbe machine, the only machine now available, and we stay very close to the pleura, less than 1 centimeter, because we started using this approach considering cryobiopsy a competitor of surgical lung biopsy and not a competitor of the regular transbronchial lung biopsy. And we freeze for 5-6 seconds. And these are specimens you are able to obtain, varying from 5 to 1 centimeter, so it's a completely different world compared to the regular transbronchial lung biopsy, with no crash artifacts. You see here that the samples are well preserved, and you don't have the typical crash artifact you can observe using forceps. But we need still standardization, because different groups use different approaches. Some groups intubate the patient with rigid tubes, and you have a larger operating field because the rigid tubes are about 13, 14 millimeters in size. Some and are straightforward, are not banded. Some groups use orotracheal tube, are a little bit smaller, they are banded. And in some groups, mainly in Tel Aviv, transbronchial cryobiopsy is performed in without intubation, in the same way you can perform transbronchial lung biopsy. Also, the freezing time is different, varying from 3 to 6 seconds, and also the use of different probes is not so clear. And another important point, not all the group use bronchial blocker to prevent bleeding, but I think this is the most important point to consider, and we will see later when we will discuss the complications. The diagnostic yield of the method. We published this paper quite recently, is our experience and a meta literature review, and you see we compared our experience with 300 cases, about 300 cases, to 150 cases submitted to VETS, and you see that the diagnostic yield, of course, is significantly higher when you use surgical lung biopsy, but you have a diagnosis of the disease in more than 80% when you use cryobiopsy. And this is true also if you consider the literature published so far. The diagnostic yield of cryobiopsy in diffuse parenchymal lung disease is about 80%. And it's important to say that with this approach you can recognize very, very complicated pathological aspect, mainly UIP. In this paper published in 2014, we had 2 extern pathologists, Tom Colby and Alberto Cavazza, and they blindly, not at the microscope, but without knowledge of the clinical aspect, assessed the specimens, and they were able to confirm a diagnosis of UIP with high confidence in 77% of the cases, and also other patterns were recognized in these samples. And this is an example of the typical UIP pattern in cryobiopsies with patchy fibrosis here and here, fibroblastic foci, and honeycombing changes. Of course, in these samples, you can perform also immunohistochemistry, MUC5B in this context in a patient with IPF. And also you can recognize chronic HP pattern with chronic fibrosis, some probably fibroblastic foci, and granulomatous inflammation, with centrilobular fibroblastic foci probably, and probably the so-called bridging fibrosis with bone metaplasia. And also bronchiolitis. This is our series. We selected patients with a diagnosis of only bronchiolitis in our series. You see here, and we have follicular bronchiolitis, cellular bronchiolitis, of course, deep neck one case, concentric bronchiolitis, and in 3 cases we had a final diagnosis of HP. So the size of the specimens is enough to recognize difficult morphological aspects. What about complications? In the first paper we published, we observed a significant rate of pneumothorax. But if you perform VATS, at least in the great majority of centers, you have 100% of pneumothorax. We had only 27% of pneumothorax. We had one patient who died of acute exacerbation 1 week later after the biopsy, and we had 4 screening failures because in obese patients, if you don't use jet ventilation, you can observe desaturation even if you just intubate the patient. So we make also this, we publish this paper comparing our experience with the data from the literature, and you see here that compared to VATS, there is, of course, a less mortality. The patient stay in hospital few days, and of course, you don't have other significant side effects related to VATS, mainly pain that can last even 2 years. And also in the literature, the pneumothorax, the rate of pneumothorax is about 10–20%. And also, the bleeding is not so important, except in the group in which bronchial blockers are not used. So if you don't use bronchial blockers, the bleeding is one of the normal aspects related to cryobiopsy. You can observe bleeding, but you can stop bleeding if you use these balloons and you stop and you have a clear operating field without big problems. Another important point is if you stay very close to the pleura, you increase probably the incidence of pneumothorax, but you significantly decrease the quantity of bleeding because the vessels are smaller, of course. This is another important consideration that Athol suggested to us. If you don't consider the complications related to the procedure, but the scenario in which you are, if you use directly VATS, in which, and the scenario in which you use VATS only after the failure of cryobiopsy. So in this context, you see that if you are in the worst scenario, in a center in which VATS mortality is high and the diagnostic yield of cryobiopsy is low, the final risk of mortality is 1.4%. But if you are in a very good center or in a very lucky center, the VATS mortality is only 2.1%. The cryobiopsy diagnostic yield is 87%. It means that only 13% of patients need VATS. The final risk of mortality is 0.3%. So cryobiopsy has significantly less side effects and less mortality compared to a surgical lung biopsy. Of course, we don't know what is the best strategy in order to have a diagnosis. It's better to have biopsy in the same segment, biopsy in different segments, biopsy in different lobes. This is still an open question. We try to answer to this question with this prospective study. We designed this study with two approaches. In one group, we performed 4 biopsies in the same lobe, in the same segment, sorry, and in the other group, we performed 2 biopsies in one segment and 2 biopsies in the adjacent segment. So biopsy in the same lobe, but in different segments. And interestingly, pathologists received the slides, and they had to make the report after one slide, the report after considering the data provided from the first sample and the second sample and so on. So we were able to assess in which sample the final diagnosis was reached. These are the two groups. In one patient, we were not able to retrieve lung tissues. This is another important point. Sometimes when you try to retrieve the cryoprobe, you feel resistance. And it depends probably on the presence of bronchomalacia. The probes does not reach the pleura or the periphery of the lung, so you freeze the cartilage plate, and when you try to retrieve the cryoprobe, you feel so much resistant and you have to stop. Interestingly, you see that in the first, we consider only UIP, in the first scenario, you have the diagnosis of UIP in the majority of the cases when you have 3 samples. This is true also when you consider the second strategy. But if you consider the third sample in the second scenario, the third sample is just the second one if you perform one sample in one segment and one in the second segment. So it means that if you perform one biopsy in one segment and one biopsy in the other segment, you can obtain the same data if you compare to 3 samples in the same segment. So probably the best strategy, at least considering UIP as a diagnostic possibility, is to have 2 different biopsy, one in one segment and the other one in the other segment. There is also an ongoing study, multi-center study, trying to assess if biopsy in 2 different lobes are more useful or even more dangerous, with an increase, as I suspect, of pneumothorax. What is the clinical role of cryotransbronchial lung biopsy? And we try to answer to this question publishing this paper. We had a very nice collaboration with a big group of experts in Forlì, 2 weeks, and we compared the data provided by cryobiopsy with the data provided by surgical biopsy in a context of a multidisciplinary discussion. The paper is very long, but just to say you that when the information provided by these 2 approach are inserted in the discussion, the confidence of the diagnosis increased significantly, but no differences between the 2 approaches. So considering the less invasivity of cryobiopsy, it's better to obtain cryobiopsy to increase the confidence of a diagnosis. So this was my last slide. I am waiting for you for the 3rd meeting in Ravenna on cryobiopsy next October. Thank you very much.
Thanks, Venerino, for this excellent presentation that is now also open for discussion. So you showed us your experience, your now very large experience that is, of course, one of the best experiences we have in Europe in cryobiopsy. I think it's important now. We are starting also this program in Portugal in different centers. So perhaps people who is doing cryo wants to have a question or to Venerino. I will have one regarding the problems with cryobiopsies. Pulmonary hypertension can be a problem?
When we started, we decided to select patient, excluding patient with PAPs assessed by echocardiography more than 40 millimeters of mercury. But later we accepted patient with an increase of PAPs up to 55, and we published 2 cases of intravascular lymphoma in which the PAPs was increased. The problem of bleeding, when you perform cryobiopsy, the bleeding comes from bronchial circulation, not from pulmonary circulation. This is clear because of the color of the blood is just red and not blue. And so you have bleeding from the general circulation for a high pressure circulation. So in my opinion, when you have an increase of pulmonary hypertension, you don't increase the bleeding, you increase the probability to intercept bronchial pulmonary connection. So just an increase of the incidence of the rate of the bleeding, not the quantity of the bleeding.
Okay.
Of course, if you have 80 milligrams of mercury, a biopsy is dangerous, but usually is not useful. So it's better to avoid this risk, of course.
Tom.
I know that cryobiopsy is a competitor of VATS biopsy, surgical lung biopsy. We don't really talk about the complications of cryobiopsy compared to forceps biopsy. And could you make a comment about that?
Yes. With regular transbronchial lung biopsy, the incidence of pneumothorax in fibrotic ILD is about 8%, 6-8%, not 2%. The bleeding is not important, but because you perform regular forceps biopsy in an outsetting in ambulatory patients, so you don't intubate them, you don't use bronchial blockers. When you have a bleeding, this is very dangerous. So I am aware of some cases that had big problems after regular transbronchial lung biopsy, because the bleeding usually is, you can control it, but if it is important, you have nothing to do, just to wait and aspirate. When you use cryobiopsy, you are more protected, and the patient, of course, is more protected because the patient is intubated, and you have bronchial blockers, and you can control bleeding without, nowadays, I touch wood, nowadays, the bleeding is not a problem at all. Of course, the pneumothorax is a little bit higher when you use cryobiopsy.
A question that I usually make to you, we have discussed this already, but I would like to discuss here. I think it is important. The big problem, I think, for us is the UIP, when the UIP features in CT scan is suggestive of a secondary cause, not IPF, but other cause. Don't you feel that in that scenario we should make biopsies in different lobes? And other questions related with this. Since our approach in surgical lung biopsy is to biopsy different lobes, why don't we have the same approach in the cryobiopsy?
I make a comment, but I need a comment by Tom. The first question, we perform biopsy in different lobes when we have clear different aspects in high resolution CT scan. It means pleural parenchymal fibroelastosis in the upper lobes and something in the lower lobe. We perform biopsy in 2 different lobes. We don't perform surgical lung biopsy to confirm a diagnosis of pleural parenchymal fibroelastosis because the risk of complication and important complication is very important. You can have fistula, you can have a persistent pneumothorax and air leakage, and so we avoid completely surgical lung biopsy for pleural parenchymal fibroelastosis, but we have a good experience with this disease using cryobiopsy without probably an increase of pneumothorax, but not important. And the second point is that we decided in the first study, we decided to perform cryobiopsy in the more affected area. I think this is another dogma. You have to perform biopsy in 2 different lobes. Why? Because we started when you perform biopsy when you had honeycomb lung. But of course, if you have honeycomb lung, you don't perform biopsy. If you don't have honeycomb lung, I'm looking for the honeycomb lung in lung histology. So we decided to go in the more affected area. And we have data on this new study regarding discordance between histology in 2 different segments compared to 1 segment. But anyway, if I have UIP pattern in 1 sample, if I have NSAP in another sample, for me it's not so important. It's just an histological curiosity, not a clinical relevant important information. So I'm not sure that biopsy in different lobes is an important approach, also using surgical lung biopsy. So for me, for us, but we don't have data yet available, probably if the CT scan is quite symmetrical, you don't have significant difference in different lobes, you need one biopsy just in one lobe. But some, he reviewed all our biopsies.
Well, I will welcome other comments. The dogma has been that you biopsy multiple lobes. And I'm not quite sure why, and I guess it's because there may be a difference from one lobe to the next. But perhaps just doing multiple biopsies in the same lobe are still going to show you that histologic difference. Athol, you're looking like you might have a comment on that. But I would agree with you. I think just getting multiple samples from different places, not necessarily different lobes.
Yeah.
Well, we've had a protocol. Michael Dusmert, as the surgeon, has driven it. This is actually a surgeon that likes to look at CT and choose biopsy sites, so you have a unique scenario. But actually, based on CT morphology, actually picking a morphologic range, which will often take you to the same lobe, but will sometimes take you to different lobes. And the amount of unclassifiable disease in a series of 150 has so far been 0 cases on histology, which is quite good when you compare it to historical series. So based simply on the CT range, wherever it might lie, and not necessarily different lobes. I do have a related question to Antonio's question. So the secondary UIPs, it has been suggested, given that you may need to search through larger surgical biopsies to quite an extent to find support for HP. Do you believe that's a sample problem with the size of cryobiopsy? So you can see this UIP, and you've shown that very, very clearly. And anyone taking part in that multidisciplinary study is immediately convinced by that. The UIP element is very graphic. But do you think there is a danger of missing ancillary evidence of HP with the smaller biopsies? And do you think that matters?
This is the most important question, the second one. You see here that we find the incidence of HP in or the prevalence of HP in our studies is low. So at least as a diagnostic field, but I think also in our latitude is low. So I cannot give you a complete answer. I think that, but Tom, you can answer better than me, that probably if you assess the samples, you can recognize some clues indicating secondary UAP. When you see UAP and you see lymphoid follicles, you can suggest collagen vascular disease, and this lesion can be seen in cryobiopsy samples. When you see some centrilobular fibroblastic foci, not only in the periphery, or some scattered giant cells or some organizing pneumonia, you can suggest another hypothesis. But Tom, again.
I don't think there's any question that the more tissue we have, the more likely we are to find something that might be a clue to HP. So I would say, yes, it's probably true. There is less tissue, sometimes 20 or 30 times less surface area. But there's the trade-off with the complication. So I mean, to me, that's an acceptable trade-off. But the answer to your question is yes.
The other possibility being based on outcome series in HP cases with UIP, that maybe we should be viewing these patients as having IPF anyway, in terms of practical management, and maybe actually giving them an HP diagnosis and removing their access to antifibrotic agents is not doing these patients a service.
And another question is, if you know more, it probably is not always better.
Going to back to BAL.
Yeah.
Two quick questions, okay? The first regarding the CD4-CD8 ratio, that it is that we have a huge variability in which concern this ratio, even in CD4, depending on even in HP, depending on the stage. So, do you really think it is important to use CD4-CD8 ratio in routine clinical practice? First,
I hope Ulrich will not answer, but my answer is no.
Yes, I think it's a correct answer. Well, but
do you agree, Ulrich?
but I use it.
Because if you see a slide, first question is if you see a CT scan, I think David can say is HP and no other invasive procedures will add more information, but this is another question. But if you see the cytological profile, the slide, you can see, yes, it is in HP. But the CD4-CD8 ratio is 8. No problem, it's in HP, not a sarcoidosis, because the cytology is completely different.
So let me put the second question, perhaps you want to enter in the discussion, regarding lymphocytes. So I think the difficulty distinguishing HP to IPF can be when you have close to 30% lymphocytes, because you can rule out IPF with this information, but eventually in many HP patients, chronic HP patients, namely if they smoke, you can have this kind of percentage in being still an HP. Do you think morphology can really help distinguishing?
Morphology BL?
Yes, in BL.
No, my opinion, no, but I don't know.
You want
Ulrich,
to say something?
Comments,
No.
Ulrich?
Microphone.
This is the last question.
All the time.
I definitely think that morphology is more...
Morphology from BAL.
Yes,
cell morphology.
Cell morphology is more important than this ratio, definitely. Yeah. So the cell morphology in sarcoidosis, you have a very homogeneous macrophage population. Yeah, the size is homogeneous. You have, except for smokers, of course. If you have a non-smoker with HP, you have very small monocyte-like macrophages, huge-sized macrophages, foamy macrophages. So that gives you already the clue that this is, and you have the additional mixture of mast cells and plasmacytes. So that's more important than the ratio. Yeah.
It is my opinion.
We still like to do the ratio, for several reasons. Yeah. I don't want to comment on that further.
Okay, Menrino, thank you.
We now go to the fourth presentation with Professor Ferran Morel, which is one of the most experienced physicians in the HP, especially in chronic HP, with a provocative title, I think. When is IPF really HP? Please.
Let me see if I can. Okay, good morning, everybody. Thank you very much for the invitation to your nice city. I'm very happy to be here in this so splendid panel of professors. Well, first of all, I want to tell to the audience that probably ILD is a difficult disease, no? Because the experts, we are all very old, no? So it takes a long time to know something about ILD, no? But don't worry, if you perseverate, you will know. Well, my talk today is to try to convince you that many of IPF, in reality, if you look all the tests and this are hypersensitivity pneumonitis, no? This is one of the things I want to convince you. Another item is that IPF. I don't know is really an entity, or perhaps we have to move and look for the etiology more than try to differentiate this entity. I don't know if I'm going to convince you. Probably not. Well, nowadays the classification of interstitial idiopathic interstitial pneumonia, as you know very well, is IPF, non-specific respiratory bronchial or for tobacco, descamative or also for tobacco, acute interstitial pneumonia. No? And also this group of very rare, the lymphocytic interstitial pneumonia, idiopathic pleuropulmonary fibrinoelastosis, that is very rare. And there is another group, when you are not able to diagnose this, we introduce in the unclassifiable. No? I don't know exactly if there are many differences between IPF and unclassifiable. Let's see if I can convince you. Well, nowadays, Dr. Hansel after will deal with much better than me with this, but we distinguish the UIP pattern in high-resolution CT when we find this peripheral interstitial and with honeycombing better in the bases. It is another slide showing this, that it is very typical peripheral honeycombing, but sometimes it's not so easy, no? When you find this possible, you don't know. Some of our introducing UIP and some no. So I think this is difficult to say exactly if there is an IP or not. And sometimes we find so very evolutionate people that you don't know if it's UIP or not, or is all honeycombing. No? So for example, this case is something that we have in everyday practice. No? So this with this slide with interstitial, very little honeycombing, very little, some consolidation. This line, you don't know exactly. We say that it's UIP or not. Probably we will be. We don't agree probably here, no. So what we say, it's IPF, it's possible IPF, is unclassifiable, and this is in everyday practice is very often. So I don't go into to say you the current criteria. Probably all we know, no? That's of IPF, reticular pattern, subpleural, honeycombing, and you must not have superior predominance. You must not have peribronchial predominances. No very much ground glass. No marked nodules, no cyst, no mosaic, and no consolidation. But in the last guidelines in 2011, we admit that this pattern of UIP can be also hypersensitive pneumonitis, collagenosis, asbestosis, even sarcoidosis, and some drugs. So we admit that it's not idiopathic. No? Some of them that have etiology. It's the same of the pathology. Tom are going to illustrate this much better, but we say that IPF criteria or WIP, usual criteria, are areas with fibrosis and others preserved, with peripheral predominance in the lobula, fibroblast, little inflammation or very little inflammation, honeycombing, without central lobular predominance, and no granulomas, no organized pneumonia. But as it has been stated before, the agreement of the diagnosis of pathology of UIP is merely 0.30. So it's very little. No? So where we are dealing with this criteria, no? So I try to make a history of how we arrived to the UIP or to the IPF, how we distinguish UIP or non-UIP. You know? First of all, it was in 1882, I think. Osler described what is much ancient, lung cirrhosis. No? But the first description of fibrosis probably In 1944, Hamann and Rees described the acute forms of lung fibrosis. And was Avery Lebo the first who described the first classification of fibrosis. No? And he described as now, no? That was the descamative, bronchiolar, lymphocytic interstitial pneumonia, giant cell interstitial pneumonia that nowadays is considered hypersensitivity pneumonitis. And after, he say, well, this one hasn't characteristic of any other, so make this in the box of the usual. And this explained me Mario Saldaña. So he told me, he trained with Dr. Lebo, and he told me when it was something not classifiable, said, put this in the box of the usual interstitial pneumonia, the usual. The usual probably is a mixed box, probably at that time, no? And from there, we have now gone to the UIP. So from this formula, we pass. How we get there? No? I think that if I am informed, the first classification was done by Dr. Costabel, no? Here, King, Costabel, Cordier, Pico, Dubois, Lynch, etc. And they define it. I don't know exactly, no? IPF, like a disease of unknown etiology, limited to the lung, with UIP histology. We see that is an histology it's difficult to characterize, and excluding collagen vascular disease, drugs, and environmental causes. But they don't exclude tobacco, no? I don't know why exactly, but because tobacco can be a cause of IPF. Well, so they say that IPF is from 2000, a new disease, a different clinical entity, no? Hence, the other fibrosis excluded, that they are not UIP, they are not IPF. Are they different entities? Why we classify for this criteria, no? So there are not very sure criteria, no? They have a different evolution. We don't know if they have different evolution, IPF and non-IPF. Perhaps the differences is because the inhalation antigen has a different particle size or different quantity of particle. For example, I believe that probably if you are exposed to minimal but persistent particles, you can develop UIP directly without inflammation. Or the spirit particles at this patient is blended with other antigens that make these characteristics in pathology, or you inhale much more time, no? Or perhaps the response of the individual is different. But I don't know if it's really a different entity. Which is the rationale for distinguish UIP and no-IP? The etiology? No, we don't know the etiology, no? in UIP because it's idiopathic. No? Symptoms are the same, UIP and non-IP. Analytical test immunology, rheumatoid factor, antibodies, antinuclear antibodies, is more or less the same, no? Also, no? Survival, we don't know exactly the survival or no UIP. The response to treatment, we don't know because we haven't discriminated the one who are not UIP, they don't receive the drugs, antifibrotic drugs. No? Well, this, after these difficulties in diagnosis, it was a new guideline, so it's a consensus in 2002, no? And then now they reinforced it was many experts, 19 experts, and 64 reviewers, no? And they reinforced the need for surgical biopsy at that time, and it's really accepted that with pattern can be also seen in asbestosis, collagenosis, advanced sarcoidosis, CHP, and even some drugs. No? So they know that there are not idiopathic all this number. So these etiologies make more difficulties, no? Because it's not an idiopathic disease. It's a disease that can be secondary to many other antigens, no? Or causes, etiologies. No? After this, after more discussion, after 10 years, the last consensus, this time is a statement, was in 2011, and that's Ganesh Raghu and 32 experts, no? More experts we have here, these experts, no? Absolutely. No? And they say that after excluding known causes of ILD, IPF may be diagnosed only by high-resolution CT only, or by high-resolution CT and biopsy. No? So they believe that you can diagnose only with a typical high-resolution CT. But taking in account that frequently in the practice, the high-resolution CT are not so typical as we would say, no? As we would look. No? And because of this, they decide to establish three different types of high-resolution CT. The definitive pattern, that is one that we want to say always, say typical disease UIP, but also possible. They introduce possible UIP, okay? But it happens when this is the criteria we are not dealing now. And in pathology criteria, also this group of experts divided the possibility of sure UIP, probable UIP, possible UIP. So they introduce many elements that because of the difficulty to diagnose UIP. These are the criteria, we're not done. So in the real world, what happens every day in our outpatient clinic, no? That's not many patients fulfill the criteria. No? So what you do, no? And even in one high-resolution CT, the kappa is low, is moderate, no? Moderate, and the histology also. So the different expert doesn't agree in high-resolution CT and in pathology, where we are, no? And even the guidelines recommend that to establish the diagnosis, we have to have a multidisciplinary discussion between or among pathologists, radiologists, and pathologists, no? Which implies a new consensus. No? So it's not a diagnosis for sure, it's a consensus between the three. Well, so in my opinion, or my point of view, the established diagnosis of IPF is not easy. No? It seems to be difficult. This is the reason why we are so old people, no? That's the ones who deal with this disease. And in addition, we know we published this paper 3 years ago, and if you look thoroughly the disease, the patients, about 50% of IPF are in reality chronic hypersensitivity pneumonitis. No? And probably there are more, because in some patients we couldn't do all the tests. So in my opinion, many of the IPF must be chronic if you look with all the tests, diagnosis tests. No? This is the story of Lancet respiratory medicine. So we look for 46 patients with a typical high-resolution CT of UIP. And at the end, 43% were chronic HP. No? And also, how many patients that we are diagnosed of IPF that are consecutive to tobacco? No? Probably another percent. No? These experts, that probably all of you were there in this paper, they recommend to diagnose IPF consecutive to tobacco with these characteristics. Smokers, or heavy smokers, being discarded the disease we have repeated until now. The DLCO must be lower than vital capacity. and or a CT scan with emphysema or centroglobular nodules or cyst, and or the histopathology, emphysema, enlargement of airspace, respiratory bronchiolitis, deep descamative, or the typical centric stele as we see in histiocytosis. No? So if you look for this, some of our patients characterized as IPF, they are consecutive to tobacco, no? In my point of view, very clearly. And also you can look if they have pigmented macrophages or hypertrophic muscular layers, I write you, no, Dr. Colby, that may be a characteristic of lung tobacco secondary. No? Well, and this is the study that was last week of Tomasetti, that is also Atoll, you were there, and Poletti. For me, it's the first study, no, make in patients with possible or inconsistent UIP, so people without IPF, no? And after cryobiopsy or surgical lung biopsy, they say that 10% are HP, and that 22 were IPF after biopsy. No? So if it's true what we say in the Lancet, that 50% of these 45 are chronic hypersensitivity pneumonitis. So in this group, possible or inconsistent, so no IPF, also about 30% are HP also. So I think HP is very frequent in pulmonary fibrosis, idiopathic or non-idiopathic. Well, which is the logical point of view? So for me, I think it's difficult to diagnose and to follow these rules or these guidelines. I think it's so because we deal with something not very clear, no? And so my proposal, no, is instead of trying to differentiate UIP or non-UIP, IPF and non-UIPF, I think it's better to look for the etiology in all the cases, no? And I think we can arrive. As Hippocrates says, some years ago, the disease are part genetics and part ambiental, environment. So we have to look for these characteristics. And which is my proposal, to search the cause in IPF and also in non-IPF that probably are possible and classifiable. No? So I propose you to follow in every center the 10 items that we use for perhaps 20 or 30 years ago. No? First of all, the first one is probably is not the same that in the outpatient clinic it was the expert or it was a fellow, because as Ulrich showed, the expert probably will define much more, will find much more exposure that the fellow is not aware. Mm-hmm. So first of all, the expert must be in the outpatient. And the anamnesis, I don't insist, but occupational, domestic exposure, proteins, fungus, hard metals, isocyanates, etc. The auscultation not only for crackles, but also for chirping rails. The chirping rail is something very characteristic, a wheeze that is inspiratory or meso-inspiratory. And in some patients, it can lead you to the suspicion of hypersensitivity pneumonitis. High CT. And we do always in all patients, even in the sarcoidosis, we do always the determination of specific IgG by ELISA method. No? Even you could do other approaches, and I worked some years ago in lymphocyte sensitization. It's a very good test, but you need 5 hours every test, so it's not practical. And even immediate cutaneous test, it works also, no? But, well, at the end, it's easier only to make IgG. But with this, you will improve the diagnosis. We always do bronchoalveolar lavage. For example, in other countries, no, even in United States, no, not many centers do bronchoalveolar lavage. And we believe that it's very useful. So if you have more than 30%, following the publication of Oshimo and Costabel, then it's sure. In our patient with chronic hypersensitivity pneumonitis, 85% has more than 20%. So if we found 20%, we believe that probably is a chronic HCP. No? Cryobiopsy, so we do always cryobiopsy because the transbronchial biopsy is not useful. I think you have not to do it, transbronchial. It's better don't do anything than do it. So cryobiopsy. And if possible, you must go with the pathologist to see the biopsy, because it's not the same, because an expert can tell you what is Oporto. Oporto is this nice city with this library, with this theater. But if you look, probably you have your own interpretation. Then can be a little bit different than pathology. So we try to go to see the cryobiopsy with the pathology. If we have a suspicion of some material, we make a culture for fungus. You know, for example, feather, humids walls, liquids, etc. No? So important also, because if you have the same fungus, then IgG specific, it's another detail. No? 8, we do inhalation tests from 7 or 8 years ago in IPF. We do inhalation tests from 30 years ago or 35 years ago in asthma and in hypersensitive pneumonitis. No? But in IPF, we do it from 7 or 8 years ago. No? And as Dr. Munoz is really an expert. They make the guidelines, the European guidelines. And we do about 2 tests every week. So every week we have 2, because can deal all the week. And so if you have a suspicion of an antigen, and you have an IgG, you have culture, you try to do a provocation. If the provocation is positive, you have the diagnosis. Because I believe that after 5 or 7 publication on inhalation test, I think the test is nowadays, for me, is validated already. You know? And if not, you perform surgical lung biopsy. But I am against the practical lung biopsy in hypersensitive pneumonitis. You have to diagnose before. I think it's very poor for the patients that the diagnosis must be made by surgical lung biopsy. You have to do it all the tests, and don't do it lung biopsy if possible. No? And in the guidelines, for example, in American guidelines, it's mandatory. No? They don't believe the diagnosis if you don't have surgical lung biopsy. So I am against this. Poor patients. No? You have to diagnose with other tests. And then also the follow-up. If you don't diagnose, sometimes following the patients, you have data, or perhaps including lung transplant, no? And you can see the pathologies. So in conclusion, in ILD and fibrosis, we have to devote ourselves to intensively to look for the cause. No? And just 3 lights for our team. We are working in Barcelona, in Vall-d'Hebron Hospital. We are about 17 staff members, and we have a research laboratory with biologists, excellent biology, who do the IgG specific test, excellent secretaries. They do all the work, and my slides. And this is our team of ILD. with Dr. Munoz, dealing with the provocation test, Maria Jesus Cruz, the biologist, excellent biologist, and the two young and future the fellows that are very intelligent nowadays. They are very intelligent, the young ones. And I thank you for your attention. And let me dedicate this lecture to so many patients of lung fibrosis to whom I have barely helped, no? And their memories are accompanying me ever since. Thank you very much.
Thank you very much. It was really provocative. The first question I would like to put you is, do you believe in IPF?
I'm afraid, no. Well, no, I think that we arrived to IPF. I don't know why we arrived to this diagnosis. Why we classify having some characteristic of high-resolution CT and some characteristic of pathologies that they are not very strict, no? So why are different? And why, for example, we discriminate the patient that doesn't have criteria of IPF for pirfenidone or nintedanib? Do you think that this is I don't know why we discriminate these ones. And in my opinion, not in my opinion, in my experience, most of them are hypersensitivity pneumonitis. So I give corticosteroids to them. I know the work of the Cochrane revision that doesn't help, but I make the pirfenidone.
Yes, well, there are some mistakes in the name IPF, idiopathic pulmonary fibrosis. I think the only good name is fibrosis, because idiopathic, okay, but we have many risk factors. We have smoking, smokers are higher in this population, and many other risk factors. Pulmonary is really restricted to the lung. So why do we have the digital clubbing, and why do we have the other manifestations from telomeropathies, macropathies, and many others? So perhaps fibrosis is the correct name, but idiopathic pulmonary fibrosis, I think it must be changed in the near future. Don't you think so?
We are stuck with the problem because we've defined IPF, and now we have therapies we are only allowed to use in IPF. So if we actually take patients who meet criteria for IPF and we find a way to call them HP, the question is whether we are damaging those patients because we are no longer allowed by regulators to give them pirfenidone and nintedanib. And it's a practical problem that we are stuck with, which takes me to my question. In your cohort, where you redefined IPF as HP in nearly half of cases, did those cases have a different outcome from the remaining patients, and did you manage them in a different way?
Yes, when we diagnose IPF because of the hypersensitivity pneumonitis, the outcome is longer. I can tell you, but I will tell you in 1 year. Because with corticosteroid, they live a little more. No? For example, IPF, 3-5 years, chronic HP 8-9 years. They don't know more than 8-9 years of life. No? Also.
And how would you manage them now, if you could?
Well, with corticosteroids, no very high dose. I make 15 milligrams, something like this, and we don't do it. I don't do it immunosuppressive, and because we don't know what we are doing, no. And but you are right. Sometimes you say, poor guy. If IPF is in reality hypersensitivity pneumonitis, why these guys that we diagnose hypersensitivity pneumonitis, they cannot have pirfenidone. No? So yes, so sometimes we say no, it's IPF, and we give pirfenidone. See.
Yeah, Ferran, this was really a very challenging and provoking lecture, right? Doubting about IPF as an entity, and maybe because you are very well known as an HP expert, you have really a high prevalence of HP patients in your referral practice. That is why you have so many patients being exposed also. In real life, if you look maybe at an institution in a big city with not so many mold exposure, not so many humidities, and you then have a lot of elderly patients beyond the age of 60, really no single exposure, and you have this UIP pattern and exclude everything else. I think this is really IPF. It is an entity. Whether you should call it IPF or idiopathic UIP, I think that would be the better term to call it idiopathic UIP, because they should have a UIP pattern by definition and excluded any cause. And they have specific genetic mutations in many of them. They have some pathophysiological features. We have now this well-defined entity. Of course, it is in the definition that you should exclude everything by the best techniques as you do. And if you have something else, and then there are all these other entities which also have been excluded, and you made a question, is the natural history different? Yes, it is. If you have an NSIP histology, a cellular NSIP, the outcome is different, prognosis is different, treatment response is different. So I think it was very valuable to separate IPF and split them out of the big pot of ILD histologies like NSIP, DIP, RP, ILD, and so on, COP, which have been lumped together before. I think it was a big achievement.
Now we have seen our series. We are dealing with our series this last 12 years, no? And I don't remember exactly, but probably we have 400 ILD patients, no? And the diagnosis of IPF in our discussion following this, and also the tobacco, no, excluding, no.
What do you mean by excluding tobacco?
No, the diagnosing ILD because of tobacco. It's following this slide I show you, no. So we say this is not IPF because it's secondary to tobacco.
So everybody who is a smoker has no IPF in your institution? If somebody is an active cigarette smoker, you don't make the diagnosis of IPF anymore.
No, see, if I can follow this slide, no, and the slide that you have done, no, there's the expert, no, and the characteristics is.
But we never called it smoking-related IPF, as in your slide. We said smoking-related interstitial lung disease. Are there any specific features in IPF patient who smokes or not, in NSIP patient who smokes or not? So it was something else. We didn't want to invent a new smoking-related fibrosis, right? Yeah. We wanted to see within the secure diagnosis we made whether there are different features. Let's say a smoking HP patient has a different feature from non-smoking. Yeah. So I know it is maybe the same as our clinical diagnosis HP paper, complicated paper, which is not easy to understand, but it's not that we invented the IPF secondary to tobacco. We never said this.
Yeah, because these are patients with characteristics.
2/3 of the IPF patients have a smoking history. If you would exclude those, you get a completely different profile. So you cannot do that. You must still diagnose IPF even in an active cigarette smoker.
Yes, I agree. But this is not idiopathic. It's secondary to tobacco. No?
Okay, I think we cannot continue the discussion.
It's a question of classification.
But the difficulty, if you have been a smoker, you may have a PAC-year smoking history of 10 or of 40 or of 70. And even if you had a definition that IPF was due to smoking, you would not be able to put individual patients with confidence into that. Your patient with a 40 PAC-year smoking may have IPF due to smoking or may have IPF by coincidence. So you can't in an individual with great confidence say that smoking is an etiology. You're only making a population statement, that there's a shift in the population. When you come to an individual patient, an average population effect can't be applied with great confidence.
Yes, but in the practical case, no, if you have all these characteristics,
lung cancer patients, and they are both lung cancer patients. It's the same with it's the same with IPF. Because, Tom, you wanted to ask?
I just wanted to make a comment. We are asking ourselves, is IPF a single entity? How many of the cases are chronic HP? There's an interesting paper in the pathology literature that just came out in a large series from Japan that if you have asbestos exposure, you are more likely to have a UIP pattern even in the absence of meeting the criteria for asbestosis. So what would we call those cases? IPF. Yet we're thinking that maybe this is just another exposure that may be a factor here besides smoking, besides chronic HP. Just a comment.
Yes, because when the expert does the tobacco is noise, is another, is not an antidote, particles and fume. In our series that we are looking now, probably we have about 60% of hypersensitivity pneumonitis, 20% tobacco, we relate to tobacco, and it left 10% IPF. 10% in our series, IPF only. Perhaps I'm wrong, but this is our data, no?
Eu só queria avisar que a sessão está a ser gravada e penso que pelo menos a maior parte dos vão autorizar que os slides fiquem disponíveis, de maneira que dentro de dias podem procurar no site do curso, que tanto a gravação como os slides em princípio estarão lá. Now we going to the last presentation. This presentation was programmed to be in the end of the afternoon, but Professor Costabel has to go out earlier, so we have now the presentation about IPF therapeutics update.
Well, thank you for giving me the opportunity to give this update on IPF treatment on this occasion. And here's my disclosure statement. Well, we have debated a lot about IPF, and I don't want to repeat it, but these are just the characteristics. 70% of them are really smokers and ex-smokers, so we cannot exclude the smokers from this cohort. The natural history is characterized by a steady decline in lung function, and median survival is poorer than in many cancer patients. And now recently we have 2 antifibrotic drugs that have shown efficacy. And corticosteroids and cytotoxic therapies are not indicated anymore for IPF patients. Interestingly, there seems polymorphisms in the MUC5B promoter seems to play a role in the development of fibrosis. This was a large cohort of 2,600 general population subjects undergoing chest CT and MUC5B genotyping, and as you can see, in those over 50 years, 9% had a signs of ILD on CT, below 50 years not. And if we would extend this to patients above 75 years of age, from the Brompton study, we have already 40% with signs of ILD on CT. So it's really increasing with age. And now if you have the MUC5B minor allele, the definite fibrosis odds ratio is 6.3, 6-fold higher risk to have a definite fibrosis. It is interesting that this risk allele also is associated with survival. But these patients have a better survival than those who have the major allele. A little bit paradox, but if you now consider that there is different survival in these cohorts with different MUC5B genotypes, and these genotypes may be not well balanced in IPF trials, this might cause a big bias. So in the future, probably, if you do an IPF trial, you should really stratify the patients for this genotype into the different arms of your trial. What can we achieve by treatment? We cannot cure IPF. The maximum we can reach is a 100% stop of disease progression, and by doing this also prolong survival. One aim also would be to prevent acute exacerbations, and of course we want to reduce symptoms by doing this. We reduce symptoms, yeah. This is the question whether we just, currently I think we can only stop the patient from having progressive symptoms, that the disease, the dyspnea will not increase over time. Since 2011, some development have occurred very rapidly. In 2011, pirfenidone was the first approved drug in Europe. The triple therapy, prednisone, azathioprine, and acetylcysteine was out after this press release of the PANTHER trial. Anticoagulants were out because of a negative trial done by the NIH. 2014, 3 years later, we had already the second drug approved, nintedanib, tyrosine kinase inhibitor. And for pirfenidone, the evidence was strengthened by the positive data from the ASCENT trial. Also, NAC monotherapy was out because this arm of the PANTHER trial also did not show a better result than placebo. This all led then to an update of the IPF International Guideline. You know that this guideline was first published 2011, and in 2011 only 11 negative recommendations were made. So 4 years before, no positive treatment recommendation at all. There were just 4 weak negative recommendations at that time. So you could treat patients, the minority, with some treatments, but now we have really 2 positive recommendations for nintedanib, for pirfenidone, very equivalent, moderate confidence in effect estimates, conditional recommendations. It means not all patients should be treated. We have negative recommendations, still 2 weekly negative recommendations for sildenafil and macitentan, but we have now 4 strong negative recommendations like the triple therapy that before were not so clear. This is really now an achievement, and you see it took 4 years actually since pirfenidone approval until this revision was made. Maybe in the future we have to update these guidelines quite earlier. What about the natural history? It's very variable. We have usually a slow progression. Some patients may be quite stable over a certain period of time. Some may rapidly progress over 1 year and die already, and then there is an event of acute worsening. It was called acute exacerbation, first by the Japanese, actually. They developed this term, and you see here the change in the CT from the honeycombing. New ground glass developed, so that's a characteristic. Within 4 weeks, increase in symptoms, new ground glass on CT, and exclusion of any other cause for this condition. So it's idiopathic acute worsening, and the mortality is high, 70% within the next 3 months, and the incidence from retrospective trials, mainly from Korea and from Japan, was estimated to be 5%. Whether this is true, I will show you by data from the nintedanib trials. FVC was considered as the most important, the change in FVC as an important prognostic factor, and it was actually accepted by the FDA now recently also as a best surrogate for mortality, because mortality studies are not feasible. So FVC decline, change in FVC was the primary endpoint in F trials. And you see here if the decline, and these are data based on more than 1,000 patients who were observed prospectively in clinical trials, placebo arms from the Intermune company. So very hard data, not retrospective data. And if the decline was below 5% absolute percentage predicted FVC, a very small decline in 6 months, the one-year mortality was just 5%. If this decline was greater than 10%, it was already 24%, the mortality. So this is really discriminating. So in the future, you will see more data about 5%, 10%. These are important cutoffs in the decline in FVC over 6 months, which have to be also considered probably in practical life situations when you follow a patient and want to see whether maybe a treatment is indicated or whether a treatment has to be stopped. So the new era now is that we have 2 approved drugs, and I want to show you now briefly the clinical trials that led to the approval. First, for pirfenidone, it is active in cell cultures and animal models of fibrosis. We don't know the molecular target of the drug, but we know that it is active from preclinical trials inhibiting TGF-beta and TNF-alpha. Approved in Japan already in 2008, and in Europe 2011, October 2014, finally after assent in the USA. And in Europe it's still indicated only for mild to moderate IPF, and also not for any other indication. We discussed it a lot, that it's only labeled for IPF, not for any other progressive fibrotic ILD currently. And in America now, in the USA, it is like nintedanib approved for all severities of IPF, not only for the mild to moderate. In Europe, the capacity trials were the basis for approval. You see here the data. It was, if you look at the pooled data, a significant effect on the change in FVC after 72 weeks, with significant p-value around a relative 30% reduction in the progression of the FVC decline. The progression-free survival time, you see, was significantly reduced, better, and also 6-minute walking distance, and especially also this significant decline by greater 10% after 72 weeks. In this case, it was 30% less patients who had this decline with pirfenidone compared to placebo. Well, after having seen the capacity data, I always said this is more or less a 30% drug, right? 30% relative effect compared to placebo. Why was this not approved by the FDA? Because there were 2 trials, 2 capacity trials. One was positive in regard to primary endpoint, one was a negative trial, because the placebo arm in that negative trial behaved very atypically. After 48 weeks, it approached the placebo arm. But this was very unique, and we could not explain the difference. If you look at the pooled data, it was significant. Well, the company was obliged to do this ASCENT trial to get approval in the FDA. This was a successful trial. The inclusion criteria were changed to enrich for more rapid progressors by having an upper cut for FVC and DCO. Below 90% was requested. The ratio was increased to greater 0.8 compared to 0.7 to exclude any small airways disease, to exclude any type of emphysema. Also on CT, you had to exclude emphysema. It was not allowed to be greater than the fibrosis degree. So it was successful. They really had a more rapid decline in the placebo arm, and it was highly positive. You see here the primary endpoint, 50% less decline with pirfenidone compared to placebo, or death. And the effect occurs already early after 13 weeks. After 3 months, you see already the same effect as after 52 weeks, and it persisted. Greater than 10% decline or death proportion of patients. If you did the slope analysis in the same way as it was later done in the nintedanib trial, this was the annual rate of decline in ml per year, you see that it was 280 ml in these rapid progressors. It was around 220 to 230 in the nintedanib trials, a little bit less, but effect was significant, a relative reduction by 42%. Very similar again as with nintedanib. 6-minute walk distance, also a positive outcome, and progression-free survival, very similar, by 43% reduction of the risk of disease progression or death, and all-cause mortality was 50% less in the pooled populations of capacity, both capacity and centriles were pooled to reach statistical power. If you looked at the individual trials, the primary endpoint times, it was not significant. It was just a trend. As for nintedanib, you just have to have a lot. These were 1,250 patients pooled together to see a significant effect. So the adverse events, we have seen them now, also in real life. GI intolerance, nausea, rash, dyspepsia, vomiting. Photosensitivity is unique to pirfenidone. Patients have to have a sun protection also on days that are cloudy, also in winter, to protect. Then the photosensitivity can be handled in most of the patients. It's different with the rash. The rash is an allergic reaction. If a rash occurs, usually the patient has also, not always, but sometimes has to stop then the drug completely. There was, in the meantime, there are several post hoc and subgroup analyses. I want to show you just this one. More severe or more advanced disease or more early disease based on FVC greater 80%, or the GAP stage, that's the scoring system, stage 1 or stage 2 and 3. And you see that the primary endpoint FVC or 6-minute walk distance, no difference whether you treat early or advanced patients. But now the UCSD, shortness of breath questionnaire, that's what's relevant for the patient's symptoms. Only in the more severe patients the drug showed efficacy. That's very interesting. Early patients have not so many symptoms, and here the drug was just on the line of identity, no effect on the drug. And the same was seen in the nintedanib trials for the St. George's Respiratory Questionnaire. Only those patients who had below 70% FVC had also a treatment effect on this patient-oriented outcome measure. Interesting data, actually. So in summary, then, pirfenidone was the first approved drug for IPF based on 5 randomized trials on 1,600 IPF patients, reduced disease progression and 1-year mortality. And altogether, I think the adverse events were supportive of a favorable risk-benefit ratio, only few leading to withdrawal due to drug effects, less than 5% actually. Now let's look at nintedanib. Nintedanib is a multi-tyrosine kinase inhibitor addressing mainly PDGF and FGF, fibroblast growth factor, platelet-derived growth factor. These are important. VEGF is a sort of angiogenic cytokine, and we don't know what role this plays in IPF. But that was the reason why patients who had a full anticoagulation actually were excluded from the trials, because there was considered not to risk increased risk of bleeding. Well, by blocking these receptors, actually several pathways of fibroblast activation, proliferation, migration, and collagen formation are blocked. And we know exactly actually the targets in contrast, the molecular targets in contrast to pirfenidone. The Tomorrow trials were the first trial. The Tomorrow trial was the first trial. It was a dose-finding trial comparing 4 different doses with placebo, and then the highest dose was effective, the 150 milligram BID dose, and also used for the approval trials, the Impulses trials. As you see here, primary endpoint was significantly reduced, the annual rate of decline with nintedanib highest dose. And the same was true for a major secondary outcome. The risk of acute exacerbations went down from 16% to 2.4% in the highest dose. Well, the Impulses 1 and Impulses 2 trials were very similar in the study design as the Tomorrow trials, never changed the winning horse, almost identical inclusion criteria, same endpoint, annual rate of decline in FVC, and the key secondary endpoints were chosen from actually the Tomorrow trial. It was the time to first acute exacerbation and change from baseline in the St. George's Respiratory Questionnaire total score over 52 weeks. Inclusion criteria, the usual ones, older age and HRCT pattern, and that was actually new and not done in other trials. That also HRCD pattern consistent with the diagnosis of IPF, but without surgical lung biopsy was allowed. And the final diagnosis of all these patients was confirmed in London. David Hansel, who is here, was one of the reviewers of all these, together with a pathologist, Andrew Nicholson, if a pathology was available. And you see, this was actually the criteria, either definite honeycombing, so it means a definite UIP pattern without any atypical features, but also the presence of just reticulation and traction bronchiectasis with a typical distribution was allowed to enter the study without surgical lung biopsy. And this is a pattern, you could argue it's a possible UIP pattern. It could also be maybe histology of fibrotic NSIP, but they were included in this trial. Honeycombing again, classical, also this type of disease pattern was allowed. Endpoints now. Primary endpoints in both trials highly significant. Met, you see the annual rate of decline was from 240 reduced to 120 in impulses 1. Again, this effect occurred early, already after 12 weeks. You had this significant effect, and disease widens, so it's continuing over time. The same behavior in impulses 2, very consistent data. Time to first in acute exacerbation, investigator reported, and that was a little bit disappointing. One trial was negative. You don't see any effect here after 52 weeks, overlapping curves. Impulses 2, highly significant effect actually. Risk reduction 0.38, significant p-value. How can this occur? So divergent. It was analyzed forward, backward, and no real explanation. There were no, maybe the more Asians in one was all not true. The only difference is, look again, the incidence of acute exacerbations in the placebo group was low here, just 5%, and here it was 10%. And that makes a difference. If you have a high incidence, the drug can reach statistical power, a high number of events, and here maybe just underpowered. But why this impulses group had more acute exacerbations, we don't know. And then if you pull the data, it was not significant, but really a trend, a significant numeral reduction. P-value was 0.08, and risk reduction was 40%. What happened if you adjudicated these exacerbations? These were investigator-reported. 100 study trials, everybody may have not followed the rules closely, so if then experts adjudicated acute exacerbations, you see a highly significant risk reduction even by 70%, and I think this is really the true effect size, because these were the true acute exacerbations per adjudication. Around 6% in the total population compared to only 2 or 3% then with the drug. All-cause mortality was also in favor of nintedanib. Less patients died with nintedanib, around 30% less patients, but it was not significant, but a strong numerical trend. Adverse events in these trials. Now, diarrhea. This is the concern with this drug. 60% had diarrhea. Most of them were actually not severe, so that only fewer than 5% had to discontinue due to diarrhea. Other side effects were nausea and vomiting, GI side effects, very similar to pirfenidone. So in summary, then nintedanib slowed disease progression by reducing the annual decline by approximately 50%. This was supported by a numerical reduction in the risk of acute exacerbations, significantly reduced risk of adjudicated, confirmed, or suspected acute exacerbations, and also a reduction in all-cause mortality. Well, there are now some new data on subgroup analysis. You know, this population was more a broad and real-life IPF population. Emphysema was allowed, Asian whites, it was a worldwide trial, and what happens if you look at male versus female age, over 65, below 65, white Asian, FVC greater 70%, below 70%, high total score in St. George's or low, never smokers, ex-smokers, current smokers, and so on. And you see for the primary endpoint, no difference in the outcome, really. Didn't matter. The change in FVC over time was identical in all these subgroups. Just to show you this, FVC below 70% or above 70%, no difference in the outcome. Even in those who had greater 90%, and that is really important, especially for the UK situation, maybe also for Portugal, where there may be some cutoffs that you are only allowed to include patients who have greater than 80%. That is not a wise approach. A patient may have 120% predicted because he had before diagnosed maybe 130% predicted, and he's still progressing. You see the progressors are the same. The degree of progression in those with good lung function, with normal lung function, is the same in those. You want to stop disease progression. You don't want to wait for 1 year until this patient reaches FVC below 90% and then start treatment. That would be not wise, but it's the approach in the UK. By the NICE for reimbursement purposes to save money. I think that is really unfair to the patient. And here, whether you have honeycombing or not, some might argue honeycombing is irreversible maybe. They don't progress as much. Or you might argue they have not yet reached honeycombing. They might not progress. Exactly the same here. Patients who would not qualify for a definite UIP pattern and have no surgical lung biopsy, that is this side actually, yeah? The same decline and the same effect of nintedanib. Or just look at honeycombing or no honeycombing, exactly the same, yeah. Emphysema. Also treat patients with emphysema and IPF. You don't need to exclude those from treatment because 40% of the patients had emphysema. Emphysema was defined as greater than 10% emphysema on HRCT, right? I think that was the definition. 40% had this, what Professor Cotin would call CPFE, and it also works in CPFE, as same as in IPF. So it may be that's the only condition, the non-IPF condition, where you are allowed to use nintedanib. It's CPFE, it's IPF, and the comorbidity of emphysema. What about the time to first acute exacerbation, the other endpoint, the secondary endpoint? You see here not the same homogeneous behavior as for FVC. Some outliers. Here, for instance, what is this? This is greater than FVC greater than 70% predicted. There is some differences in the disease severity, obviously, in regard to the secondary outcome, acute exacerbation. And I want to show you this in more detail. This is also, I think, a fascinating post-hoc result, or no, it's a predefined analysis actually. And you see, first one thing, those who have below 70% predicted have an exacerbation rate of 16% per year. That is really relevant, 16%. And if you treat those with nintedanib, it goes down by 50% to only 8%. So here the drug is really working. If you have a good FVC above 70%, you would not need the treatment with nintedanib for prevention of acute exacerbation because the rate is low, it's just 3%. And that is important if you consider which patient would need treatment. I would consider a patient who has lung function above 70% and no symptoms and doesn't change over time if you control him with his FVC, if he remains stable below 5% predicted change over 6 months, over 1 year, you can wait. But if a patient has already reached FVC smaller than 70%, you would not wait until he shows disease progression because you could do something for the patient in preventing acute exacerbation. And the number needed to treat would be just around 1 to 7. It's not a very high number. So I think that is really something you should consider. So in comparison then, I think if you look at ASCENT and IMPULSES, so in ASCENT, all had a definite UIP pattern on HRCT, almost all, and many of those had even a surgical lung biopsy to confirm it, and no emphysema, no small airways disease. Here, 40% had emphysema and was just requested a UIP pattern, either definite or possible. So this more real-life situation, this more artificial study population, that doesn't mean that this drug only works in this population. It's just for the trial. It also works in real life. And the FVC percent predicted, these were more progressed patients, 68%, here 82%. Here a high screen failure rate, 70% had a screen failure here. Here only 30% because of this very strict inclusion criteria. And so then we have now these current treatment options. You may choose between pirfenidone and nintedanib. Here are the clinical trials, the different side effect profile, photosensitivity here compared to diarrhea with nintedanib. You take here 3 times 800 milligram capsules, here twice 150 milligrams daily. That may be also an argument for the patients. But again, in Europe, pirfenidone is only approved for early to moderate IPF, whereas nintedanib is approved for all severity stages. Well, what about the future now? Key questions for 2016. Of course, we have now really make a prompt and correct diagnosis. We should not delay the diagnosis. We have data that the diagnosis delayed from start of symptoms in 50% more than 1 year. This was a survey at the AIR meeting back in 2013, and don't think it has changed much. Only 30% of IPF patients are diagnosed within 4 months of within 6 months of symptoms development, and that's a shame actually. If a patient has fine crackles on auscultation, and 95% have those, the GP should then send the patient, if he is an elderly patient, directly to the pneumologist or to HRCT and not send him to the cardiologist and exclude maybe cardiac disease. Which drug first? Combination therapy currently not. It's not proven that it's better, so I don't recommend combinations. It should be a sequential therapy. When should treatment be started? When should it be stopped? Very important questions. And the problem is that really the current drugs cannot cure IPF. They have shown to slow disease progression by 50% on average in clinical trial populations, but not in every patient. And some patients will not respond to treatment. Should then a stable patient with mild disease be treated? I said before already, I think we can wait because the patients may really behave very individualized. These are data randomly selected 50 patients from pirfenidone trials, placebo arm. And what you show here actually in these placebo arms that some patients went up by 10%, and this patient, he declined in 3 months by 20%, and then suddenly he remained stable. So if he would be included here, you would see no treatment effect here, a significant decline, a very heterogeneous behavior. But on average, again, how many patients are stable or improved? You see here in the ASCENT trial, no decline, even improvement or very zero change in FVC, 10% in the placebo group. What about, this is a significant decline, 10%. What about the 5% limit? I said 5% is for me a patient who is really stable because the mortality is low, only 5%. These were in the impulses trials in the placebo arms 40%, close to 40%. So would you treat these 40 patients? I would say you can wait and just make very regular lung function tests, and if it declines by 5%, repeat it to confirm it and then start the treatment. Because as a smaller trial by a German group, Andreas Günther, and an Italian group, Carlo Albera from Turin, they pulled their patients, real-life patients, 76, and you see that pre-treatment measurements before pirfenidone, and those who had a greater than 10% decline, they really improved than with treatment. Mean average duration was around close to 1 year. But those who had no decline, there was no treatment effect on average, at least visible. And as I said before, this early disease is even present in 60%. It was an intelligent Brompton trial where all patients who had abdominal CT also underwent a thoracic CT, volunteers aged over 75 years, and they had the typical IPF distribution, subpleural, basal, reticular ILD. Would you say all these have IPF, and would you consider treatment prophylactically? For sure not, yeah. So again, what are realistic treatment expectations and long-term efficacy? Just run through the impulses on briefly, and you see if you then continued nintedanib, open label, and those who continued, they had impulses on over 1 year, the same decline as during the trial, and initiating nintedanib the same. So you can obviously, you must not expect that the drug it loses effectiveness if you treat for longer, which has been considered for some kinase inhibitors in cancer at least. And the real life expectancy, the real life experience is our own one, which we published in a German paper. So safety and tolerance side effects, 58%, dose adjustment, 18%, so you have to dose adjust. But after 1 year of treatment in real life, only 33% had discontinued, close to 70% still stayed on the treatment. You can expect that 2/3 of your patients are still happy with the drug after 1 year. So just the last 2 slides, whether response to IPF therapy may be predictable. This was an analysis of the Panther IPF population in regard to TOLIP and MUC5B polymorphisms. And just to show you the data, those who had the TOLIP genotype, the minor allele, the CC, the major allele, and this was NAC, they had a worse outcome with NAC actually, a worse outcome. And those who had this TT genotype did much better with NAC. It was an 85% reduction of endpoint-free survival. That was a stronger effect actually with the current antifibrotic drugs, but limitations, very small number of patients post hoc. We have to wait now for a confirmatory trial, which I think they do now at the NIH. That would be sensational. We would then have the first predictor of response to therapy, and we need many more of those because we don't know, should we give nintedanib, pirfenidone? We have no predictor of the response to treatment currently. And I want to finish by saying this, and thank you again for your attention.
The IPF therapeutics open to discussion.
I have one comment and one question. The comment is on NICE, and people think that NICE stands for the National Institute of Clinical Excellence. It does not. It stands for the National Institute for Cutting Expenditure.
Excellent comment. Good.
But can I just make this point, agreeing strongly with you, and I'm always worried when I do agree with you, but
very rarely, right?
Very rarely, so we're probably both wrong. But this business of not treating very early disease, I think the problem may be using FVC to make the judgment. So NICE as a body have decided to declare that this is a good way of measuring disease severity, but we don't do that in clinical practice. We look at the FVC, we look at the CT, we judge whether there's emphysema as well, we look at symptoms, we look at DLCO. It's our bread and butter. It's what we do.
I agree.
Yes.
We don't disagree. I think there are several criteria, and in real life you really put all of them together, right?
And that's how we should make the judgment. Then my question is this: we've got endpoints, and in clinical practice you know full well, you look at a patient, you look at the change in FVC, you look at the change in DLCO, you look at symptoms, you look at imaging change in selected cases. That's what you do.
Right.
And at the end of all that, you have a much better idea of progression.
I agree.
But in these trials, the primary endpoint is this artificial focus on one variable.
Right.
Your comments?
I agree. This is trial situation, and so probably in real life, you can argue that you don't repeat CT very frequently. You assess the symptoms, you do that, and if a patient says he has more symptoms, you do an exercise test, and if this is also deteriorating, you start treatment even when the FVC is not declining. I agree with this, It's just one parameter which I brought as an example,
Can I ask you 2 questions?
Yeah.
Me. So in which concern the stopping treatment, you stand on, besides side effects, of course, you stand on specific criteria. This is one question. The other one is about your experience in which concern combined therapy.
So the stopping criteria is very difficult for disease progression because in real life, in most patients, you don't have pre-diagnosis lung function measurements. If you would have those because he has been treated maybe before by other drugs, you could estimate whether his decline and his personal deterioration by symptoms is the same with the drug, and then you could decide to stop the drug. On the other hand, if you see a patient who has really a greater than 10% decline in 6 months, I think that is really an enormous progression. Then you might again discuss it together with the patient, whether he also feels that he didn't benefit from the drug, and then you may decide to stop it. But I think just these stopping decisions should always be discussed with the patient, and not just you tell the patient you have now progressed by 10%, I will decide to stop the drug. That is not good. If the patient wishes and he feels that he might have a benefit, I would still continue with the drug. Yeah.
Independently of having acute exacerbations in mind, so because it can decrease even higher the FVC in a shorter period.
Yeah, I would even then continue. If he survives an acute exacerbation by high-dose corticosteroid pulse, maybe added by cyclophosphamide if he doesn't respond, and he has still maybe a quite well-preserved quality of life, is still moving and mobile, I would continue then the drug and not stop it. On the other hand, if he has really then a very difficult situation, is going to palliative care after such an event, which frequently happens, that he's bedridden, high oxygen, I would stop the drug. Yeah.
Other questions?
And combination therapy,
yes.
There are data, a small trial from Japan about combination of nintedanib and pirfenidone in 23 patients, and there were a little bit more side effects. But the major issue was that the peak plasma levels of nintedanib were reduced to 60% more or less, so that there is an indication that you decrease the efficacy of nintedanib if you add pirfenidone. And there are no data on efficacy. So both drugs are now tested in combination by both companies separately, not together, but over a short period of time we will then know that they are safe in combination, but probably the time is not long enough to show any data on better efficacy if you combine the drugs. So this will be left open also in the future.
Just one observation on the stopping rules. So NICE require them. But after 18 months, 15 IPF experts from around the UK met in an advisory board meeting, and somebody asked, after 18 months, have any of you had a single patient where there's been a problem with the stopping rule, i.e. the patient wanted to go on, but you were supposed to stop? And the answer was nobody in the room had a problem. And everyone said that if the decline was 10% of predicted normal, so a drop of 60 down to 49, almost all patients had some side effects from the drug, and they actually wanted to stop. And now they would want to switch. So while the stopping rules may seem autocratic and nasty, in real life, they don't matter.
Okay.
And it's this 80% threshold that is the unacceptable situation.
In the NICE, yeah. And the stopping rule is greater than 10% decline in 6 months or in 1 year?
One year. Any 1 year.
Any one year.
So if you're stable for 3 years and you decline on the 4th, you're supposed to stop.
Okay, yeah. No, but then it's fine. Then you see that after 4 years you have this, and before you were stable, right? Yeah.
Yeah, but then I guess you can now switch, so it isn't bad.
You can switch, yeah. And again, that is also better. We have currently only 2 drugs, and to combine them initially would be not wise. You know, if you have to fight an enemy, and you have 2 weapons, and fire both weapons at the same time, it's always bad. First the one, and then the second one, yeah. And the same for doctors. They are really advised not to give all the drugs they have at once. Otherwise, the patients will not like them anymore and come back. Yeah, that's okay.
My question is about anti-reflux therapy.
Reflex therapy, right.
We have now a consensus about IPF, a Portuguese consensus, that is published, and Professor Costabel made the editorial. Thank you for that. It's a very nice editorial. And you don't agree about the anti-reflux therapy prescription in all patients, but only in some. Can you detail?
Yeah, you actually had the same recommendation in your consensus statement as the international guideline, that they did not change the recommendation on reflux, and they said they had a weak positive recommendation to treat all IPF patients, no matter whether they are symptomatic or not, or whether they have reflux or not. And I cannot agree with this, especially because we have now good data from both trials, from the nintedanib and the pirfenidone trials, where we looked in the placebo arms, and around 40% of those in the placebo arms got reflux therapy. A good number, and there was no difference in outcome. Even in the pirfenidone trial, those who had a little bit of poor lung function had increased respiratory infections and pneumonia events with reflux therapy. So that based on this, I cannot make a recommendation to treat patients who are asymptomatic and have IPF. Only symptomatic patients with reflux should be treated.
But doing the consensus, sorry, we didn't have that information of the
yes, it was.
Yes.
It's maybe important to understand the structure of the revised guideline. The voting was made by people who were not IPF experts. The IPF expert panel were not allowed to vote on the recommendations, and there is an editor's note which basically states that the IPF experts disagreed with the recommendation on reflux. And you know, if you've got an editor's note written in a guideline, the disagreement must have been explosive.
Right, okay, good. Thank you for this important comment from a guideline member.
And
right?
It was.
Yeah, you will remember, and you remember very well.
Well, thank you very much. It was explained. Terminou a sessão da manhã. Neste momento são 13h48. Eu ia propor que nos encontrássemos às 15 horas na sala 3 da parte nova da faculdade, no CIM, onde iremos ter os workshops da radiologia e da anatomia patológica. Os colegas que estão inscritos no curso de teórico-prático têm almoço, ok? E muito obrigado por terem estado toda a manhã, foi uma boa oportunidade.